Welcome to the National Cancer Institute of Kenya, where our commitment to excellence is embodied in our service delivery charter. Our vision is to be a leading authority in cancer prevention, management, and control, while our mission is to oversee the delivery of responsive, high-quality, sustainable, and evidence-based cancer prevention, management, and control through multi-sectoral coordination, research, public formulation, regulation, and advocacy. Now, let's explore the services we offer and our expectations of you as a valued client. Customer care. Our dedicated customer care team is here to assist you with the management of inquiries, compliments, and complaints. Whether you choose to visit us in person, make a telephone call, or send an email, we aim to respond promptly. For physical visits, we strive to assist you within 10 minutes. Telephone calls are addressed within 1 minute of phone ringing, and emails receive our attention within 24 hours. Should you file a complaint or compliment, expect acknowledgement within 3 working days. This duration may vary based on the scope of the investigations required. Stakeholder coordination. We are committed to providing you access to information on stakeholders, partnerships, and collaborations. Our formal communication channels ensure that your requests are acknowledged within 7 days. Technical support. If you require technical support, such as document development or review, workplace programs, or capacity building, our team is ready to assist. Submit your official request letter and you can expect acknowledgement within 7 days. The service is provided free of charge. Monitoring and evaluation support. For monitoring and evaluation support to programs and projects, we are here to help. Timely submission of reports and availability of resources and logistical support are provided on a need basis, free of charge. Cancer-related public information. Accessing cancer-related public information is crucial. Whether through physical visits or our digital platforms, we encourage you to provide feedback and we promise to acknowledge within 3 days and respond within 2 weeks. The duration may vary depending on the complexity of your request. Provision of cancer monitoring and research information. If you're seeking cancer monitoring and research information, submit your application for data access. We acknowledge within 7 days and provide this service free of charge. Management of cancer registry. Prompt notification for surveillance is a priority. Expect acknowledgement within 60 days, and this service is offered free of charge. Regulation. Our regulation services include accreditation of institutions or organizations and the designation of licensing of these entities. For an application for designation, expect acknowledgement within 24 hours. Applicable charges for this inspection and licensing are applied. Community awareness activities. Join us in community awareness activities and cancer campaign initiatives. If you have a formal partnership request with a detailed activity plan, we acknowledge within 24 hours and this service is provided free of charge. Coordinate research. For research coordination, submit your request for information or partnership. We acknowledge within 24 hours and this service is provided free of charge. Human resource opportunities. Explore human resource opportunities with us, whether it's internship and attachments or staff recruitment. Submit your field application form and supporting documents, and you can expect acknowledgement within 14 days of the advertisement date. Positions are typically filled within 6 months of the advertisement, and these services are provided free of charge. procurement of goods and services. If you're involved in the procurement of goods and services, our services include the request for pre-qualification and the submission of quotations and tendered documents. Expect acknowledgement within 14 days of the close of the tendering period. All timelines adhere to the Public Procurement and Disposal Act 2015. Payments to suppliers of goods and services. If you are a supplier, ensure timely payment by providing evidence of delivery and user acceptance reports. Submit your invoices and relevant documents, and payments will be processed within 30 days in accordance with the Public Procurement and Disposal Act 2015. The National Cancer Institute of Kenya is dedicated to excellence and respect in service delivery. In line with our core values and the Constitution of Kenya 2010. Should you encounter a non-conformity to these standards, please report it to our Chief Executive Officer. National Cancer Institute of Kenya, Landmark Plaza, 6th floor. PO Box 30016000100, Nairobi, Kenya. Or you can call us on telephone number 0795 01 2568 or 0717 38 9120. You can also find us on X, formerly Twitter, at NCI Kenya, or the Commission Secretary, a Commission of Administrative Justice, Prime Minister's Building, 6th floor, a PO Box 20414 00200, Nairobi, Kenya. Or you can call toll-free number 020 227 0000 or email certificationpc@ombudsman.go.ke, or you can visit the website www.ombudsman.go.ke. Thank you for choosing the National Cancer Institute of Kenya. We are here to serve you with compassion, dedication, and a commitment to making a positive impact in the fight against cancer.
Tuko na chanjo kwa wasichana wetu wa miaka 9 mpaka miaka 15 kuzuia hawa kwa ugonjwa wa saratani. Ile HPV vaccine that is going to assist our girls in matters to do with cervical cancer. We have enough vaccines in Kenya to make sure that all our girls aged between the ages of 9 and 15 can be given those vaccines so that we can protect them from cervical cancer that is destroying and killing many girls and many women in the Republic of Kenya.
Can I get live here at Citizen Television? We may be smiling, but we'll talk about a very, very serious topic, because cancer, you must know someone who knows someone who knows someone who has cancer or who has died from cancer or is a cancer warrior. Like we have right here, Evelyn Alela. She has detected breast cancer and she has fought it. She's a true warrior. And we have 3 specialists as well. We're going to be talking more about that. Evelyn, first of all, so when you first found out, what went through your mind?
The first thing I thought about was, I'm going to die.
Yeah.
Because for the longest time we knew that cancer is a killer disease. And my family has a history of cancer. I lost my father to cancer of the liver. That's about 23 years ago, thereabout. I had lost a cousin, a first cousin, to breast cancer. So it was like, okay, it's my turn now. But I said, all right, let's deal with this. So I went to, that was now, when the diagnosis was done, my doctors gave me the treatment plan, which I went through. Very difficult, especially the chemo part of it. But I was very fortunate that I had an amazing support system my family and my friends were really, really there for me. And I cannot overemphasize the importance of having a support system when going through this sort of experience.
Yeah.
So
how many chemos did you go through?
I had 8 sessions of chemo.
8?
Yes, I had 8.
And did you lose your hair? Did you, like we always hear all these stories?
Yes,
Yeah.
I lost my hair, I lost my eyebrows, I lost my eyelashes.
But you got them back now.
Yes, I got. Yes, I did.
Well done.
By the time I was done with chemo, all the hair started growing
Grew
back.
back.
Yeah, it all grew back.
Do you feel, you wake up sometimes and say, you know, I feel a pain here, I feel there's something, it may be coming back. Do you get those fears?
Yes. So what happens is after someone has gone through cancer, whatever another person would think is just a headache or a backache or chest pain, for me, it's, oh my God, could I be having a recurrence on the chest? Could I be having a recurrence on the bone? Or is it coming back to the brain? So I always worry when I have any sort of pain or when I'm tired, I'm like, okay, what is this now? So yes, there's that fear that it could be recurring, but we just soldier on and push at the back of the head and carry on with the day.
Yeah. Mheshimiwa, your daughter was 10 years old.
Yes.
10 years old. Very few people think of children getting cancer. When you first heard she was sick with cancer, how did you feel?
Jeff, my daughter was the most healthy baby. Of all my 3 babies, she was the baby who never fell sick at any particular time. So I believe she was the most healthy baby until one day I was called from the campaign trail by the mother. And she tells me our baby has some tonsillitis that we need to see a doctor. So I told her that's a simple thing, tonsillitis, go to get through that, get checked. So when she went to the doctor told her, you need to see an oncologist. So something clicked in her and she called me, she told me, what is this? Why should we see an oncologist because of this? So, and to stop everything and come back. So when we went to Nairobi Hospital and the doctor told us the worst, showed us this baby has cancer.
Oh.
No, the doctor called me and told me, can we take a walk? He told me, Shuma, this is dangerous, this baby has a problem, this baby has cancer.
Did you try and get a second opinion, or did you?
No, it was so serious then
Yeah.
because within 3 days, the baby could not even, the platelets in the blood were going down within an hour. So we were getting donors at the hospital.
Yeah.
Every minute we needed a donor, every minute we needed a donor, every minute we needed a donor. So finally we flew to India. We did a bone marrow transplant.
And she found a match?
Yes, the brother donated, the brother to stop schooling and join us in India. The brother donated bone marrow to her. She seemed to be recovering, but all of a sudden things went haywire. The organs failed. She had sudden all the organs failed at once. So she had organ failure, acute organ failure, and she passed on November, that was on November 5th.
At 10 years old?
At 10 years old, a very beautiful girl.
Dr. Mary, are there many cases of children, or do you see more and more cases of children with cancer?
Well, Jeff, the statistics are alarming. On daily basis, many of cancer incidences, cases are recorded on daily basis. Let me confirm to you that the National Cancer Institute of Kenya is the custodian of all cancer data in this country. We have a national cancer registry, and this includes data from childhood cancer diagnostic and treatment centers. They are on the rise. But interestingly, between adults and children would present in a manner that you can hardly suspect because they would present with the normal illnesses. You've had Honorable Munene here mention that it was tonsillitis. Trust me, that child had been sick for the last couple of years because carcinogenesis process does not begin, in a month and you become unwell. Yeah. Most likely, the bone marrow is an organ in itself. And acute lymphoblastic leukemias, which his daughter was diagnosed with, interestingly, when diagnosed in a setup where there is the requisite, infrastructure, where we have the right human resource, the right commodities, Even without bone marrow transplant in the West, acute lymphoblastic leukemias can be treated with a cure rate of more than 80%. And we've demonstrated, when I began my practice, we had almost 100% mortality rates in acute lymphoblastic leukemias. But right now, at Moi Teaching and Referral Hospital, where I've worked for the longest time before I joined National Cancer Institute of Kenya, we have cure rates of more than 50% over the last 5 to 10 years because of a program which is dedicated to treating children. And in this country, for us to address childhood cancers, the approach is totally different from adults because these are guys that you cannot screen. These are people that you need to have high index of suspicion for you to make a diagnosis. So having our healthcare workers to learn how to suspect so that you don't end up treating a pneumonia or maybe pain in a prolonged time and ultimately it becomes cancer when it has spread. I want to, reference in this world, we have 75% of cancers are diagnosed in the West. 25% are diagnosed in low, medium income countries where Kenya is one of them. But unfortunately, 75% of mortalities are in LMICs. What have they got it right that we don't have it here? But allow me to appreciate that so much has changed over the last 10 years in our country. Our government has really invested both in adults and childhood cancer treatments. And we're not looking at only treatment. The most important thing is to make the right diagnosis. Okay,
Dr. Busahal, let me ask you this. Yes. Dr. Melly just mentioned 75% of cases are diagnosed in the West, right?
That's right.
Do they treat that cancer different? And I'm saying this, as a pure layman.
Yes.
Muzungus with cancer.
Yes.
Are they treated different? Do they have different treatment as opposed to us of melanin skin? Do they treat us different, or is cancer cancer?
Cancer is cancer, and the treatment is the same. Whether you are in New York or you are in Mandera, the treatment is the same. We have what we call treatment guidelines, and they are uniform across the world. What differs are the details in terms of access and diagnosis. Diagnosis requires you to be able to define the cancer at molecular level, at genetic level. And then once you identify it at that genetic level, you can identify what is even causing that cancer. We call them driver mutations. And then you can give a targeted treatment for that particular mutation. So if you identify that, this mutation is what is causing the cell to multiply without control, then you can give a target for that particular mutation.
So is our problem
access? Our problem is access to diagnostics and access to targeted therapy. That is where the problem is.
Jeff, after losing my daughter, thinking about children at cancer, I find out as the country moves towards primary health care, that we are training community health promoters who will be in the villages. We really need now the oncologists and the doctors to do a lot of health education. Because as Dr. was saying, you find a baby who doesn't concentrate in school, who is not doing very well at times, a few headaches here and there. Yeah. The notion in the village, you can never suspect a baby or take a baby for cancer screening in the rural village. Yeah. Because it clicks in my mind that once in a while my daughter will come home, she's healthy, but she says, I'm feeling very tired, so she wants to go and sleep. So you find these were signs maybe that we didn't catch early enough. So I find there needs to be a lot of health education on the issue of children, because we have done a lot of education on grown-ups, how to check breast for cancer, how men need to be checked for prostate cancer. But have we educated our nurses, our clinical officers, our promoters on how to detect early signs of cancer in children?
That's a great question. That's a great question for the CEO right there.
Yes.
CEO, that's a question for you.
Well, we want to appreciate the government of Kenya through the leadership of His Excellency Dr. William Samoei Ruto for this UHC. This has been great for Ministry of Health. The whole week we've been in Kericho. Yeah. and this will culminate with Mashujaa Day celebrations on Friday. We've showcased a lot, and the National Cancer Institute of Kenya has been part of the institutions that have been showcasing and even conducting screening, public awareness in the community. Now, community health promoters who are going to man a PCN, a primary care network, they have cancer messaging, amongst many other information that we have loaded them with. Within those 100 households that one community health promoter is going to, man, we have information on how to prevent. We have information on, and not only cancer, because, cancer becomes a health issue only when you become sick.
Right.
And that is why NCI is in this country to use a multi-sectoral approach. Our risk factors are in the community. Our risk factors are in the environment. As much as we could be having genetic risks, and I do suspect my fellow panelist, Dr. Alela here, they could be running, a genetic lineage of hereditary disease.
Right.
And we have genetic screening now for such patients who are at high risk. But then majority of us, we have to address this thing in the community. If we are to win this battle, Jeff, we will win in the community. We are not winning in the clinics.
It's
however,
machinani. Yes.
However, we still have to treat those who are diagnosed. And remember, investing $1 in prevention, you save $16 in treatment. And as we all know that I treat cancer like terrorism because it terrorizes your physical body. Your social life is gone. Your psychological life, you lose your mind. You've had a lot of mental health issues related to cancer. I've had patients sitting in the clinic. Sometimes you even break down, as a doctor, and you wonder, especially when you're treating kids, you wonder, oh my God. Yeah. These little ones, what have they done? They've not even lived life.
Correct.
For them to be diagnosed. Many people have attributed, many myths that people have attributed cancer in adults. Sometimes people think I have sinned. What have I done? They blame God.
Or you've been bewitched.
Bewitched.
Correct.
So many of that. But at this point in time, with the launch of community health promoters, that is going to be strong in creating public education and awareness in the community. The message.
Hold that thought. Yeah. Evelyn, a lot of viewers are asking, what were the signs, the warning signs, when you first found out you had cancer?
There were no warning signs at all. I just discovered a lump on my breast one day when I was taking a shower. And that's when I decided to go and have it checked because it was big. So I wondered how long it had been there because I didn't feel it the previous day. So it was like it appeared overnight, but definitely it didn't. I just happened to discover it on that day. So there were no signs at all.
Was there pain?
No pain.
No pain?
No pain.
And how soon after did you decide, let me go and get this checked?
I got a little bit busy, so I had it checked after about 2 months. And so that is when the whole program started. I was sent for the initial diagnostic tests. I had a mammogram done, which of course came back and showed that there is suspicion, and then sent for an ultrasound. Then after the ultrasound, I was sent for a biopsy, which was now the final confirmation because they took tissue and then they found cancer cells on the tissue that was taken out of my breast. Yeah. Yes.
Dr. Busahal, look, for us men, we hate going to doctors.
That's right.
You know that.
That's right.
And prostate has become a big problem.
Yes.
Especially, 50 plus or 60, whatever.
Correct.
What should we do? What's the message to men out there? Because, like you were saying, early detection is everything, huh?
Yes.
The longer you wait, the higher your chances you're going to die.
Exactly.
What do you tell men out there?
What I would tell men out there is that men are the most common cancer for which men are at risk is prostate cancer. And prostate cancer can be silent for many years. Prostate cancer is one of those cancers that you can stay with and live up to 100 years without ever knowing that you had it.
Yeah.
Yes. So sometimes you can detect prostate cancer early and treat it, but you may be treating a cancer that never needed treatment in the first place. But you can also leave it, and then it spreads and it causes premature death. Yeah, so prostate cancer is an interesting cancer that usually requires individualized discussion. And so what we usually recommend for men is that we encourage them to have some personalized discussion with their doctors about prostate cancer.
Real quick.
Yes.
Every human being has cancer cells in them, right?
That's right, yes.
Right? Everybody has cancer
Yes,
cells.
yes,
It's
yes.
just that something that triggers them.
Exactly.
Right?
Yes, there is a predisposition to cancer. You see, the cell is always multiplying. What we see as a human being is just an accumulation of very many cells, and those cells are multiplying at a very high rate. And during that multiplication, things go wrong, which can cause cancer all the time. The body has mechanisms to detect when those things go wrong and eliminate those cells.
Right.
The body launches an immune system to early cancer cells and eliminates them. So most of the time, yes, what you are saying is true, that is happening. And quite often, it escapes these checks and balances in the body and develops cancer.
And this is why you're saying the smoking and the alcohol and all
Exactly.
these things trigger.
Before we leave Daktari
Mheshimiwa.
on those predisposing factors, I would wish Daktari to enlighten us a bit on the issue of our diet and the use of pesticides in this country. Because I watched a show here another day, a report by Enric Bo Foundation, where they say that 70% of pesticides being used in Kenya in agriculture, most of them are bad.
A cancer causing.
Most of them are bad in other countries. You find what happens in Kenya, we have a pesticide bad in Europe, but Europe allows them to continue producing it for export to other countries where regulations are not very tight.
Right.
For example, something like Loudap. If you go to the village, people don't want to cultivate their land, they use Loudap. Loudap is commonly used. But you found in other countries, people have even been compensated for having been traced that the cancer was caused by Loudap. Go to most of our farms in Kenya today, where we are producing fruit and vegetables for export. You found a greenhouse there, you told that greenhouse as fruit for export.
Right.
So we are not using chemicals. But that other one is for local consumption.
Yes.
So that one we are using
okay.
everything. So I would really tell this issue of pesticide.
That's a good
I think
point.
you have been poisoned as a country.
Dr. Mary, that's a good point there.
Well, it is quite challenging. Thank you, Honorable Munene, for bringing this up. You know, we have mapped these risk factors. And from the NCI, in the past year, we have been doing cancer mainstreaming among its ministries, departments, and agencies, because these are areas where all these risks are. If you go to manufacturing, companies, there's a lot of exposure, there's a lot of chemicals. If you go to landmines, if you go to Kwale by the landmines, if you go to our farms, chemicals that we are using. I was in Kericho yesterday, and the rates of acute leukemias, even for adults in that region, is quite alarming. And I've treated many patients from that region. I do suspect most likely it's because of a lot of chemicals by the tea farms. And, we have herbicides that we are using. We are asking, institutions, because if you are certainly having some risk factors, please, if it is possible to avoid. But if it is part of contribution to another product that is unavoidable, we want to protect those who are exposed. But if there are chemicals that have been banned in other countries, I think that question is good to be addressed, actually, through the National Assembly.
Through?
I'm taking it back to him.
You're throwing it back to me. I agree.
We have to enact laws in this country, Jeff, that are going to protect the public. Remember, nobody should die of a preventable disease. And health is a right to every Kenyan. It's enshrined in our constitution.
Correct.
So where there are risks, we have been discussing today the whole day. I had a meeting with civil society organizations. How do we enact laws to control tobacco use in this country? How do we enact laws to curb, through KEBS and through KRA, we have to make sure that anything that is imported in this country must pass the test. If it's going to be used, by proxy, or if it's going to be consumed. He's mentioned about food. Food is the next pandemic in this country, and actually in the world. Yeah, we had COVID. But food, obesity you had is a risk factor. A lot of chemicals that are used in preservation. Let's even talk about fast food that we are using. If you saw the advert that Kenchik has displayed, of course, some of us are not excited with that because you cannot reduce cancer awareness for breast to chicken on the plate.
Right.
Yeah, and we are asking Kenchik that they would have to do something about that. I'm putting on this tie. It's Breast Cancer Awareness Month.
Correct.
We really want to address these things with the seriousness it deserves. Colon cancer, we are eating a lot of refined food. You wondered why more cancer now. We are not eating, the
local
inorganic food that we ate from when we were young. Right now we are eating a lot of refined food, and constipation is a huge risk factor for colon cancer, amongst many other risk factors. So on issues that we have confirmed that it's a risk for cancer, we need laws. And National Cancer Institute of Kenya has lined many, suspected risk factors that requires legal, implication. And we're going to have a meeting with our Parliamentary Health Committee soon, parade them, discuss, and these should be bills, these should be motions that should lead to bills, and it should be laws to protect and prevent our people.
Good points. Okay, Mheshimiwa, he's throwing it back to you, and I'll get to you in a moment. I need to take a break right now and come back and talk about that and other issues. I mean, there's so much stacked against us, so much. I mean, we're staring at the abyss here. I mean, we have enough issues, enough problems with, price of fuel and other issues. And now this disease is coming and taking over. I mean, what can be done? What do we tell our people? We're talking to two experts, a legislator and a cancer warrior. That's our topic of conversation. And we're asking you, what is your cancer journey? Let us know at Koinange Jeff at Citizen TV Kenya. Make sure you use the hashtag JKLive. JK Live takes a break. We'll be back in a moment.
Last year, cost ya cancer peke yake ilikuwa 40 billion Kenyan shillings. Na sasa hivi Social Health Authority kupitia zile funds 3, Primary Healthcare Fund itashughulikia mambo ya screening, HPV vaccination, amutalipa chochote, italipwa na serikali. Kuna Social Health Insurance Fund ambayo tumeulizwa sisi wote tuchangie. Nitawauliza marafiki zetu viongozi pamoja na wananchi wa Western Kenya tuweze kulipia 2.7%. Sio pesa nyingi kulingana na ile matibabu utaweza kupata. From yesterday up to now, Madam Waziri, we vaccinated more than 2,000 girls. Na tuta roll out hii program sio Bungoma peke yake, si Western Kenya peke yake, bali katika nchi nzima. Mniruhusu tu nimalizie hapo, na tutaendelea kushirikiana na departments za health katika counties kupitia uongozi wa governors na wabunge na wananchi wote. CHPs, nyinyi ni jeshi letu, muweze kuwahamasisha. Waziri, mwezi ujao niko na mkutano na CHPs kule Naivasha kutoka representation, nilikueleza kwa ofisi. Tunataka kuwaelimisha kuhusu kansa ili waweze kuwaeleza yale ambayo yanajiri sasa duniani na katika nchi hii, na lazima tuhakikishe hii janga la kansa tunashinda. Tunashinda ama tushindi? Tushashinda. Tukiwa na waziri mchapakazi, si itawezekana? Asanteni sana, Mungu aweze kuwabariki.
Okay, finally, under access to information category, institutional category, the first runners-up award goes to the National Cancer Institute. Congratulations. For advancing citizens' health rights through dissemination of information. Between the year 2020 and 2023, the National Cancer Institute made significant strides in cancer prevention and control in partnership with various organizations in Kenya. Collaborating with the Media Council of Kenya, government bodies, and media outlets, the National Cancer Institute focused on raising awareness about cancer across TV, radio, print, and social media platforms for 3 years. This partnership resulted in comprehensive media coverage during Cancer Days, effectively reaching a wide audience. The Institute emphasized the importance of tailoring cancer messages in local languages to ensure inclusivity among diverse population groups. They also prioritized accessibility for persons with disability by transcribing prevention and control messages into Braille, audio-video clips, and infographics. To enhance outreach, the National Cancer Institute expanded awareness campaigns on television and FM station, reaching approximately 28.2 million people nationwide. Thank you so much, and congratulations to the National Cancer Institute.
Attention all Kenyan men. Prostate cancer screening just got a whole lot easier thanks to the innovative PSA test kit. Gone are the days of lengthy and complicated procedures. With the new PSA test kit, you can now get your results in just 15 minutes. Here is how it works. Simply visit your nearest testing center, where our knowledgeable officers will guide you through the process step by step. A quick and painless blood sample is all it takes. Then, you can relax while you wait for your results to come in. In just 15 minutes, your results will be ready. They'll be printed and presented to you on the spot. Our testing officers will be there to explain your results and advise you on the next steps based on your individual situation. Remember, early screening saves lives. Don't wait until it's too late. Take the first step towards protecting your health today. Visit us now and make your health a priority. Together, we can beat prostate cancer. PSA test kit. Easy, fast, and life-saving. Get screened today. This message has been brought to you courtesy of the National Cancer Institute of Kenya.
A 1-month-old can be diagnosed with cancer. And to me, that is painful. And as you've said, children are very innocent. But what are some of the causes? What are the underlying factors that contribute to childhood cancer, and how can they be prevented?
Well, Brian, the reason why I mentioned earlier on that the strategies that we use in adults is different from children is cancer causation is a long process, what medically we call carcinogenesis. And for children, since they are young and they are, can be diagnosed as early as a day or a month into their life in this world, we do not have them being exposed to the risk factors other than one, which is hereditary. This means genetic predisposition. So when these children, and my teacher taught me not to call them kids, it's disrespectful.
Americans like saying kids.
No, but it is disrespectful. These children, when they are born, they have not been exposed to what we call trigger factors. Of course, for everyone to be diagnosed with cancer, there has to be an imbalance between their genetic makeup and their immunity. So if your immunity is weak, and you have genetic, let me say, instabilities, then you just need a trigger factor to initiate the process.
What are some of the prevention measures? Because I know you're talking about some hereditary.
Well, our government currently shifting into, promotion and prevention, generally in approaching health, moving away from curative, which is very costly. But in children, it is a bit different. We do not have so much focus, especially in cancer, on prevention. We are actually focusing on quality treatment because, as I've rightfully said, whatever we would always want to prevent is on the risk factors. But then there are not much risk factors. So what we would do is to encourage parents when they are carrying, these lovely babies in utero to avoid potential risk factors, alcohol, tobacco use, which are known to be risk factors for adults, exposure to chemicals. But from evidence, this has not been the main reason why children get diagnosed with cancer. It is genetic instabilities that, and their immune, which is compromised. So if you have a child, for instance, who has HIV, we have what we call prevention of mother-to-child transmission of HIV, because HIV affects the immunity. But there are many other causes of immune compromises other than this. So it's important that the approach, and we would want to educate and inform the public on importance of, quality diagnosis and quality treatment for childhood cancers. That has to be very, very clear. We are not focusing
specified.
so much. It is specified. In our country, the leading types of cancers in children are different from adults. We are talking about leukemias. These are blood cancers. So we are talking about lymphomas. These are cancers that affect lymph nodes, those glands that we have them in our armpits, that we have them in our groins. Remember when we were growing up, if you have a wound in the leg, then you find a swelling by your groin. Those are called lymph nodes, and they are important in providing immunity for us. But now when you get cancer, they overmultiply as a way of responding to a challenge that they are facing, and they swell. That is lymphomas. We also have kidney cancers in children. If you look at what our focus is really, we also have brain tumors among the children, and head and neck cancers called nasopharyngeal carcinomas, and there are many other cancers that affect children as well. So our focus is, how do we then diagnose early? By educating parents, educating healthcare providers, even our medical team. They need to know, how do we suspect? High index of suspicion in children matters more than teaching people about prevention, because for children, if you diagnose early, you can actually simply treat them and they get cured. And these are the approaches which the West are using. A mother should know when they are, showering their little baby, what telltale signs can they be doing? For example, if you want to diagnose, cancer of the kidney, we call them nephroblastomas. We are asking mothers, when you are cleaning, showering your babies, be touching their tummy. You can pick something which is bumpy, and you can report early.
Proper care, up close care, because sometimes we have parents who are very busy. As soon as they start taking care of the children, maybe the first 3 months, the 4th month, amerudi kazini, then it becomes hard for them to actually just take care of the baby.
Parents, you cannot afford not to take control and charge of your children while they are growing up. And we have to do this jointly. Give you another example. In school, you see a kid who, while the others are playing, looks lazy, cannot run. When you ask them to walk, they breathe very fast. And also, parents at home, when you see your child is not very active, sometimes it could just be this child is weak because they have low blood levels. And these are among the first telltale signs for leukemias.
How best we can have the conversation on cancer, especially childhood cancer, and of course reducing the survival gap. But of course there is policy, Dr. Elias, that at National Cancer Institute of Kenya, you are on the front line to make sure that the policies that govern such spaces are able to aid individuals in prevention matters when it comes to cancer. Talk to us a little bit about that.
Well, thank you, Brian. It's important for me to mention this before I mention about policy. Get your child, suspect the symptoms, and get care from a facility, from qualified healthcare workers. When you see the doctors are going to interrogate father, and the doctors will ask for additional investigations, whether it's laboratory or diagnostics through imaging, scans, and further give a care plan once a diagnosis has been made. In our country, we have very few centers that treat children. And I want to inform our listeners and those who are viewing that we have Kenyatta National Hospital, we have Moi Teaching and Referral Hospital. Those are our major hospital in public that provide childhood cancer care comprehensively. We have other centers that we are trying to build now. Our approach in Kenya is regional centers for cancer treatment for children, not every other county. We cannot afford. The numbers are few. We have to make sure we have regional centers. We also have private centers that have really helped. Aga Khan, Gertrude's Hospital, they are also part of the centers that have done a lot of work to support our children, and we appreciate everybody. Now, we would want, as a country, we are at a wake of UHC, Brian, and NARA. Currently, the leadership, the Kenya Kwanza government, bottom-up economic approach transformation agenda has health as their major pillar. And from a policy perspective, we have we want to improve on health systems because you cannot treat cancer in isolation. You have to improve on health systems generally, making sure we have the right infrastructure, we have the right technology, we have the right commodities, and these are speaking to each other. We should also develop national cancer control plans. We currently have a national cancer control strategy, that we are implementing. It's a 5-year plan. We are into its first year. And childhood cancers are largely, in this plan. If you don't have a roadmap, then you would not know where you are heading. So for us to eliminate childhood cancers, we have a plan. And right now, we have a global initiative on childhood cancers, which is captured in our plan. But that by 2030, we should have cured, improved cure of our children who are diagnosed with cancer by 60%. So that that is how we are closing the gap. That's how we are reducing it. Now, developed countries are at 80% survival. We would also want to get there. We are at 20. So we would want to make sure we reduce this survival gap. We also have to make sure we implement, cancer workforce training. The only way we can address challenges that we have is through training, education, community health promoters. We are training them. We are training those who are also in mainstream curriculum-based programs, in our medical school, nursing schools, in our laboratories, in our radiology centers. And right now, we're even doing advanced training of pediatricians, those doctors who are already qualified to take care of children. Further training, advanced training called fellowships in pediatric hemato-oncology. University of Nairobi is providing that. Moi University is providing that. And we are encouraging a lot of training on the same. The other thing that is very important that we are also looking at is advocacy. We have to advocate. We are looking at establishing cancer registries for children. And cancer registries...
Specifically for children.
For children. We're not going to use the adults one. And, data is very important. We will use it for national planning. We will also use it for research so that we can answer our questions. The other thing that is important that we are looking at is strengthening referral pathways. You had asked me that question.
Yes.
It is in part of our policy documents because proper referrals, very important. We have appreciated that many patients present themselves to our hospitals, but because of bureaucracies, delays, untimely referrals, patients get their disease progress. Because the challenge that we are facing right now, even in adults, is late presentation. And sometimes it's the system delays that we have these challenges. So we are working on making sure that availability of essential medicines to treat children. WHO is asking, very soon, we hope we can be one of the countries that are going to receive essential medicines for children.
We will.
And
we must.
Finally, using guidelines and protocols in treating our children so that we standardize care. Whether you are in Nairobi, whether you are in Mombasa, whether you are in Garissa or Busia, there has to be standards and there have to be guidelines and protocols that we are using. We also want to make sure there are treatment packages. You've heard about SHA, our new health, care financing, social health authority. NHIF is gone. Are you aware? It's
I'm
dead.
aware.
It's gone.
I'm aware.
It's repealed. So right now, we are in the wake of social health authority. And here, there are packages that we are using to make sure comprehensively anyone diagnosed with cancer, not only children, are able to comprehensively be covered, because cost has also been a challenge. You know, it's very expensive to treat cancer.
Yes.
You've had people going outside the country. Do you know something called bone marrow transplant, Brian?
Heard of it?
You
Heard
know,
of it, yes.
We are actually destroying all the cells in your bone marrow when there is an indication, you know, and infuse new cells that are going to multiply. And by destroying the entire bone marrow, we'll have destroyed where cells multiply that becomes cancer, and we infuse new cells that are going to multiply. You know, right now, Nairobi West Hospital is able to do bone marrow transplants, and Kenyatta National Hospital might be the first public hospital to do the same.
Yeah.
So, and packages are going to cover that. And
Yes. So, on that note, because of time.
Because of time, but
yes.
next time, give me enough time. Brian.
Yeah, next time we're going to give you enough time.
These are serious matters
Yes.
that we really have to.
It doesn't
educate the
end
public.
today, Daktari.
So
it doesn't
make
end
sure
today, Daktari.
Next time,
Utakuwa na enough time.
You give
yes.
us enough time. And
Yes.
not only me,
Yeah.
we have so many experts,
Yes.
so many specialists across the country that will come here and educate these young people who are listening, and also, you know, the older ones who are fans of Young
Nation
People
FM,
program,
yeah.
right? Thank you very much, Brian,
Yeah.
for having me here. I think it's been fun.
Daktari, it's been amazing having you. Here we have something called Makofi Ka Olomide, just to say thank you for giving us a chance to have a front seat on the cancer situation in children, and especially in the children of Kenya. You've talked about 3,200 infections, new infections yearly, and it was quite peculiar and quite sad to get to experience that. But thank you so much for the insight.
Here are 6 signs of pancreatic cancer to watch out for. 1. Yellowing of the eyes and skin, also known as jaundice, is often the first symptom that people experience. It's caused by the buildup of bilirubin, a dark yellow-brown substance made in the liver. When pancreatic cancer blocks the bile duct, it causes bilirubin to build up and keeps it from getting to the intestines. Other indicators of jaundice include dark urine, poop that is greasy or light in color, and itchy skin. 2. Pain in belly or back. Pancreatic tumors can become pretty large and can be quite painful. This type of cancer can also affect nerves around the pancreas and cause back pain. 3. Unintended weight loss. Weight loss is another common symptom, and people with pancreatic cancer will often have little to no appetite. 4. Changes in blood sugar. It's rare, but some forms of pancreatic cancer can destroy cells that make insulin. This can cause a person to pee a lot and feel hungry and thirsty. In other cases, it can lead to changes in blood sugar that don't trigger any symptoms at all. However, blood tests can detect these changes. 5. Nausea and vomiting. When cancer tumors block the stomach, food can't get through. This leads to bad nausea and vomiting after meals. 6. Enlarged gallbladder or liver. Pancreatic cancer can even block the bile duct and cause the gallbladder to get bigger. If it spreads, it can also increase the size of the liver. Healthcare providers might be able to feel these changes during an exam, or they can spot them with imaging tests. You hear this time and time again, but it's important to remember, if you see something, say something. Talk to your provider if you start noticing some of the symptoms mentioned. They can examine you and run tests to rule things out. Waiting will only make things worse or lessen the chances for successful treatment or survival. Don't ignore the signs. Tell your provider right away and get the help you need.
My name is Mercy Osoro. Mercy Osoro is also a staff in NCI. I'm also a cancer warrior. I was diagnosed with Hodgkin's lymphoma. It's a subtype of lymphoma. And I've survived. This is now my 19th year since I was diagnosed with the cancer. I was diagnosed in the year 2005. The journey was not easy because I had a swollen mass on my neck, that right now it's not there. It was so big and it was coming slowly. It was just swelling slowly. It wasn't painful, but it was just swelling. So I was taken to the nearest dispensary. Nothing was diagnosed at that point. They only gave me painkillers. Then when I went home, the mass persisted swelling, and then I just went on with my education. By then I was a teenager, but it wasn't when I was in class 8. The mass was too big until my neck. I was just walking while bending the neck. I was taken to Moi Teaching and Referral Hospital, where my diagnosis began. Later on, we went to Medihill Hospital, where I underwent the surgery. The biopsy was done through that surgery. Then during those days, we used to wait for 3 weeks for you to get your results. Then the results came back positive that I had cancer. It was so difficult to my family to accept, but they had to. So one of the pediatric oncologists was consulted, Dr. Constance Tenge, who is now professor, and she took me through the treatment. She advised my parents that I'll be going for 12 cycles of chemotherapy. Then I began well, the first one, the second one, then the third one. During those days, there was no NHIF. So my dad had to look for finances for me to get the treatment. But when I went through the 3 cycles, the mass subsided, and I looked to be okay. Then my dad made a decision that there's no need for the treatment because the mass has gone off. We can now stop there the treatment. But in the real sense, he had no money because there was no NHIF even to cater for medication. So I stopped the medication. After a year later, the mass came afresh to both sides, and they were really big and they were so aggressive. So I had to go back to the hospital, and I met again with Professor Tenge. Then she advised on medication again, and she told me you don't need to stop the medication before it's over. So I began again from cycle 1, cycle 2, but at that moment there were no drugs. So I used to wait for other patients who had money to buy the drugs, and then the leftovers to those bottles of drugs, they were used to treat me as mercy. And I went on with the treatment from cycle 1 up to the 12th cycle. I completed in the year 2007. After completion of treatment, later on I encountered some side effects of the drugs. I got some very serious side effects that I'm living with to date. my heart was affected. I had a left side heart failure that I was diagnosed with in the year 2007. I began treatment in the cardiac center. The drugs that are very, very expensive that I'm using up to date. So the treatment of cancer has its own side effects that most of the warriors are going through right now, that you have to use drugs in your lifetime. So that's what we are pleading as the survivors, as the warriors, that even in the medical cover, that the survivors to be considered. And I could also wish to encourage the parents to as a parent, when the child is diagnosed with cancer, in that I'm a childhood cancer survivor, make the right decision to your child, because if the right decision was made to me, I couldn't have dropped out of medication. And also I would like to encourage those who are diagnosed with cancer that cancer is not a death sentence. We are here, we are living. I'm living a normal life. I'm like any other person who has not gone through any medication of cancer, and I'm doing very well. I'm doing my duties as an officer in NCI, even back at home. So cancer is not a death sentence. I'm here to encourage you that when you're diagnosed, just follow the instructions of the doctor and you will come out strong, like here we are. As a survivor, I encourage parents to allow their children to go through the HPV vaccine to control this cervical cancer. And even for men, for prostate, it's good to go for checkups. Do frequent checkups to know yourself better, and you will save life. And also even for lymphoma, parents, be checking your children. Be checking your children for these lymph nodes. Sometimes they can begin without you knowing. Check your boy. Check the lymph nodes. How are they? An early detection saves life. There is this dawa ya kienyeji. It is called sagithiet in some areas. You find that when you are diagnosed with cancer, then you are taken also, you're being told with those old people that you go for herbal medication. Herbal medication doesn't help. I used it and it never helped me. It kept on worsening the situation, because these herbal medicine, they don't have the dosages, and they don't know, the research has not been done about them. So when you are diagnosed with cancer, kindly follow the doctor's instructions. Don't go for herbal medications. They don't help. They never help, and they never helped me. Thank you.
CEO, NCI, Kesha representative, Ken co-chair and board members, Dr. Bo representing the DG, Ms. Phoebe, the executive director of KENCO, warriors, cancer survivors, caregivers, all protocols observed. Good afternoon.
Good afternoon.
Yes, thank you so much. It is indeed a privilege for me to be here to join you in this gathering. we as the Ministry of Health, we are here to interact and have meaningful engagement with you to understand what you're going through and see how we can ultimately improve social health authority in Kenya. As you know, we are a people-centered ministry. Our goal, our vision is to have a people-centered approach. So even for cancer, you as the cancer survivors give us the critical information that we need in order to improve the services. And so we don't take it for granted, and I hope, Dr. Nelly, this will be a first of many interactions. You know, at times we may sit up there in the national office and forget what's happening on the ground. And when I listen to your stories, indeed I'm touched. We have documented everything, and we will definitely come up with interventions to address all the concerns. And so maybe just to inform you, UHC, Universal Health Coverage, our sister has clearly said, PRISCA, it's about affordable, accessible quality of care. When you look at the NHIF model, it looked mostly at the employed. They were the ones who were benefiting, okay? And it was really restricted to a certain proportion of Kenyans. But now we are moving to universality. How do we ensure that there is health care for each Kenyan at every region, at every corner? And I know even one of our sisters had talked about, staying in the mashinani and how can she access care. That is the current situation. And coming from the medical profession, I have seen it, where a woman comes and you're telling her surgical intervention is 200,000. Where does she start? And ultimately, let us remember that the donor fund is dwindling. We cannot rely on the donors. Today, as you can see, the elections are going on in the US. And those, we cannot just be there waiting to hear what's coming up. Are they going to donate? Are they going to contribute to HIV treatment, malaria, diarrhea? We as a country need to be self-sufficient. We should stand on our feet and ensure that we are able to take care of health matters as a country. And that is actually what UHC looks into. So it looks at care for the poor or the financially constrained and the very rich, all contributing to one pot. And those who cannot, that's the ones we are calling indigents, then we will also support them free of charge. It is looking at everyone. The people who have cancer, the people who have HIV, etc., all contributing to one pot. Because ultimately, we need to be self-sufficient. The donor fund is dwindling. We need to stand on our feet as a country and care for the sick in our country. And this was actually the vision of UHC. When we are looking at the health financing component, you will also notice that there are different areas we look to. There is the high burden diseases, like in children, they have coughs, diarrhea, we have malaria burden. We have women who are giving birth. We have what we call the catastrophic expenditure diseases, like now renal disease. They need to go for dialysis, chemotherapy also. So people can use a lot of money to get these services. So you can see the burden of disease is high in certain areas. People are dying in others. People are spending a lot of money in other areas. And yet we have a tight fiscal space following the financial bill. So meaning that the money that was given as we transition, it wasn't enough to cater for all these conditions. And so for us, we started with the key priority diseases, even as we build up to improve the health insurance. So what am I saying? These are the early stages. Just like a small baby who is, now we are 30 days or 31 days old, we don't expect the child to run a marathon or a sprint. But we hold that baby and patiently wait, yeah? Give them the right food, encourage them, and gradually they will And that's why we are saying, let's not throw away a good thing. This social health insurance will cover every Kenyan. It's universal. It looks into quality. And there's a lot that we are doing as a ministry to ensure that we will offer quality care services to Kenyans. And so let us embrace it and let us be patient. We take note of the teething problems or the transition challenges that you have faced, and indeed we will take into action to ensure that you're able to access these very services that we are talking about. And so cancer remains a significant health challenge in Kenya, but we are proud to share that we are making considerable strides to support the patients at every stage of this journey, from the prevention up to the recovery. Cancer continues to pose a serious health challenge in Kenya. As we know, it's a leading cause of illness and death, and we take note, and that is why it was a high priority, and that is why this will be one of the many, many meetings we will have to ensure we're improving the quality for cancer prevention up to rehabilitation and recovery. So while we were discussing out there with the colleagues, one of them told me an interesting thing, that in MTRH a study was done, and on this study they found that after patients were diagnosed with cancer, only 25% could start treatment and only 50% could complete. And so that is why we are looking at UHC. How do we have early detection? How do we ensure that we onboard as many cancer patients as possible, and how do we ensure that they go through the whole spectrum of management, rehabilitation, recovery, etc. There may be challenges previously with the diagnosis, but as has been said clearly, that our focus again is on screening and early diagnosis. We have expanded screening for breast cancer, cervical, prostate, and colorectal. They are accessible from level 2 up to level 6 in Kenya, so that we can ensure that we are having early detection. And with early detection, we know that the survival is longer, the quality of life is better, and the financial benefits are better. You will not spend so much money. And that's why you will see that there is really a lot of focus in this ministry on early detection. For NHIF, it was mostly management. So once one has been diagnosed, and you know, before you get all those screening done, and before you start medication, a lot of time has lapsed and the disease has spread. But we're trying to break that by ensuring that we have early screening and detection. Again, this one will help for better outcomes and also for better quality of life. And you will see that that is why our focus is on the primary healthcare level. We have a primary healthcare fund to ensure that people are accessing. And as cancer survivors, I hope that you will encourage more and more Kenyans to go for screening early. This one will be accessible at primary healthcare level. Upon registration, one can access the services free of charge. Again, for diagnosis and testing, accurate diagnosis we know is the first step towards effective treatment, and we are now covering critical diagnostic services, including the cytology, histology, immunohistochemistry, which is making it easier and more affordable for patients to receive clear diagnosis. This was not previously covered by NHIF, and if it was limited. We are bridging the gap with Social Health Insurance Fund and the Social Health Authority. So again, a brilliant progression on that. For imaging and screening, access to advanced imaging like X-ray, bone scans, ultrasound, CT scans, MRI, and PET scans are really crucial. And again, these are covered under the Social Health Insurance Fund. What I would like to inform you, dear colleagues, because I have had two colleagues also concerned that they had not received their PET scans. As you know, during the first week of transition, we had a lot of challenges. The thing is, we were rolling out something nationwide. And so before all the facilities could be contracted, before people could be able to have a seamless access to services, we had a bit of challenges. But now I can assure you, when you go to KUTRH, you will get your PET scan, you will get your imaging services there under the Social Health Authority. So for radiotherapy coverage, for patients requiring radiotherapy, we are now covering all sessions needed for a complete course of treatment, rather than a limited number that was covered under NHIF. This means that patients have a peace of mind knowing they can complete their radiotherapy without interruption. We take note of the systemic treatment support that was extensive with the NHIF, and we want to tell you that our oncology package includes the essential therapies, including chemotherapy, targeted, and immunotherapy. I have taken this down, the amount, and we will work as a team to see how we can expand. We were actually engaging with the colleagues, and we were thinking of even strengthening the access programs, advocating for reduced taxation, and then as well as thinking of bulk procurement among others. And what I have tasked the team to do is come up with interventions that we can have, so that we can have reduced cost for systemic treatment or other treatments for cancer patients.
Space. Mimi nikiwa daktari ambaye anapigana na hili janga la saratani pamoja na madaktari wenzangu, Dr. Nderitu yuko hapa, on behalf ya madaktari wote katika nchi hii, wale tunawaita front line officers, na si madaktari tu bali wale wote ambao wanahusika, hata wauguzi, wale counselors, social workers, wale ambao wanaweza pia kugundua, pathologists, laboratory specialists. Mimi ningependa kushukuru Mwenyezi Mungu siku hii ya leo. Kila wakati mimi hupenda kuanza maongeo yangu kupitia hadithi ambayo ni zile shida wagonjwa wanapitia klinikini. Tumepata nafasi kuweza kuhusika katika matibabu. Na ninajua wale ambao siku ya kwanza wakielezwa kuwa umejulikana kuwa na ugonjwa wa saratani, machozi ni mengi. Wangapi walilia hiyo siku ya kwanza? Leo ningependa tulie machozi ya nini? Ya furaha. Na leo sitaongea sana kuhusu wakati ule, bali tuweze kuongea kuhusu sherehe tulio nayo leo hii tukishukuru Mwenyezi Mungu, si ndio? Na ningependa pia kusema asante kwa sababu ya nyinyi ambao mumehusika katika kupigana ili uwezekano ya kutibu ugonjwa huu ukue katika nchi yetu. Cancer advocates, tukiongezwa na chairman wetu na executive director wa KENCO pamoja na board ya KENCO na wale CSOs wote. Leo ninasema with confidence kuwa kama nyinyi amungehusika wakati huu, probably hatungekuwa mahali tulipo, because nyinyi ndio mnajua mahali kuna uchungu zaidi, si ndio? You know where the rubber meets the road. And therefore, when you stood firm and spoke in loud voices, I always say I cannot talk about cancer journey and successes without mentioning the civil society, without mentioning the cancer experts who, more than a decade ago, with a lot of passion, they faced the leadership in this country and asked that we should speak a different language. We should have a different conversation. We should make sure that we address this problem with the seriousness that it deserves. Ni wakati hule mulisimama mukashika mabango vile mmetembea leo in our streets, wakati hule na serikali ikasikiza kupitia kwa Wizara ya Afya. Hiyo ndio wakati serikali ilijitolea ikahakikisha kuwa lazima tuweke resources ili tuweze kuaddress this problem with the seriousness it deserves. Hiyo ndio sababu ulisikia Daktari Nderitu akitueleza kuwa miaka 10 na sasa hivi kuna tofauti mwingi. And I will tell you with also confidence, even internationally, regionally, we are a star country. We have made so much progress. Our stakeholders who are in the industry, Ms. Jackie Wambua will tell you, Roche spans across Africa and across the globe. Likewise to Pfizer, AstraZeneca, all those who are playing in that space. There is so much investment in our country right now. I was in a meeting recently and we were ranked with Egypt, South Africa, Morocco, and Algeria as the leading tier in cancer care in this region. So ningependa kusema you are lucky, even if we still have a few challenges. Ningependa tuweze kushukuru yale serikali imefanya kupitia Wizara ya Afya, kupitia the National Cancer Institute of Kenya, ambayo ilizinduliwa zaidi ya miaka 10 zilizopita ili iweze kuhusika na kupigana na hii janga one by one. Na ningependa kusema hivi, sasa tuko na uwezo afadhali, hata ingeweza tungependa tuweze kuwa na uwezo zaidi. But what we are able to do right now, one thing that I encourage my team, and speaking from a strategic position, we need to tighten the quality aspect of care. So that even as we move forward to continue providing care, what we really want to interest our people is even that care that we provide, let it be quality. So that we can have many people who are surviving. So that we can have many people who, if we don't provide that care across the continuum, they should not fall on the way. And as I speak to that point, shall we observe a minute of silence for our colleagues, our fellow patients who may fell off before today. Thank you. We loved them, and they had hope that they will live to the fullest of their time. But because of challenges that may have been inevitable, haikuwezekana. So tunashukuru Mwenyezi Mungu. From the National Cancer Institute of Kenya, we endeavor to work with you this journey. I remember when I assumed office, I called all the civil society organizations and I said, let's have a conversation. We have been delegated this responsibility and we have to work together. We have to work with the civil society. We have to work with all the partners, government and non-governmental. We have to work with private sector. We have to work with patients. And I promise to you that I cannot do, or NCI cannot do what you are doing. But with your strengths and the strengths and capacity within the National Cancer Institute of Kenya, we should win this battle together. How are we going to do that? I want to appreciate all the panelists who are here this afternoon. That was quite an engaging, and I can actually tell that we are speaking the same language.
We are addressing this problem from different corners, looking at it across the entire continuum of care. Tunafanya hima na bidii, kila mtu amejitolea, na hilo ndilo wito wetu hapa leo, kuwa tuweze kufanya hima pamoja. Ningependa hata kushukuru our religious organization. I want to thank the leadership at the temple which our brother is from, that have blessed us with lunch this afternoon for our survivors. It means we are one family, and we are going to win this battle together. We want to make sure, a lot of us have talked about prevention. It is true, and it is the mood of this current government that we put more focus on prevention. My role at the National Cancer Institute of Kenya is to look for resources towards cancer space. When you hear Dr. Meli has supported us for Uber, you have actually used your resources to facilitate your own services, and that is how we should use taxpayers' money. Ama namna gani? Let our resources be able to address where the biggest problem is. And we are going to put all the efforts to make sure that there is a countrywide HPV vaccination. We have low-hanging fruits. Cervical cancer should not kill any lady, any woman, whether young or old, in our country. Other countries have done very well, and we are able to work with them closely to know what is the secret. Australian government is the first one leading to eliminate cervical cancer. We have targets. 2030, we have been given targets by WHO, which we are signatory to. And being a signatory, there are many initiatives towards cancer care, ambayo sisi lazima tuhakikishe tumeweza kuifikia. I also want to mention to you with confidence that cancer is a bit complicated, and it also takes personal responsibility. My work and my team and all of us is to communicate what you need to do. When you talk about early detection can only happen if we undergo screening. We have communicated. Therefore, I am calling all of us, survivors, and those who are watching, viewing, listening to us this afternoon. It is your responsibility to be screened for cancer. And we will sing this day and night. Breast cancer, prostate cancer, cervical cancer, cancer of the esophagus, colorectal cancer. We have modalities that we can use to make sure that we screen you, and some of them are very cheap. You know, a lot of time we talk about cost, but there are some screening modalities that cost 0 shillings, especially where there is capacity in our institutions. We have done a lot to make sure that our county governments have capacity in primary health care, beginning with enhancing capacities with a lot of partnerships. Let me single out the Empower Clinics and the First Ladies Forum for initiating this idea. And I've mentioned a lot of times to Her Excellency Dorothy Nyong'o, who with her family have been true champions and advocates of cancer space. Can we clap for them, please? When I was going for my postgraduate training, I shared with Madam Dorothy recently that I went to Africa Cancer Foundation and asked for funding because government was not able to fund my foreign training because they had become the light then. Fortunately, government heed my request and they funded my training outside this country. And right now, we are happy that we have capacity to train locally as we are building that capacity. Allow me to also
ladies and gentlemen, mention that the sacrifices that you've made as survivors is a true embodiment of hope for us, so that even as we invest resources, we know there is value. We know there are results. Any investor, when we are resource mobilizing, people ask for value. And I think the value is what we are seeing here today. The value is those of you who braved all the side effects, those of you who went through mutilating treatments, whether surgery or radiation, those of you who vomited, those of you who lost your hair, those of you who have complications that are lifetime, we celebrate you. We shall support you. We shall walk with you this journey to the end, and we will make it comfortable for you. I think that is the hope that we need to have today. And as we work towards winning this battle, I have mentioned again and again that we have so many mushrooming cancer centers across the country. And one of our roles is to provide standards and quality. We shall help you from a government perspective to make sure that when you go to a center, truly they have capacity across the continuum of care, so that you do not get the wrong surgery for the wrong diagnosis. Has it happened before? So that you are not treated for breast cancer and later on you are told you didn't have cancer. Yet you have suffered a lot. It is our responsibility to make sure these institutions are established, they are running, and they are providing quality care for you. We also want to invite you as patients, and it is a global call right now that thou shalt not do anything unless patients are involved. And that is why we are having this discussion today, and we shall continue having it. I recently had a recruitment process at the National Cancer Institute of Kenya, and I insisted that we cannot have a staff which the patients themselves are not part of. And we were able to recruit some of you to be part of establishment at the National Cancer Institute of Kenya. They will share with us real experiences. They know the challenge they went through. We are also struggling with understanding ourselves. Do you know why sometimes you get treated and you probably get more side effects, and you wonder why me and someone else did not get that much side effects? We still are working towards understanding ourselves. And we have now committed resources into research. We are going to win this battle if we are a research-oriented country. And this research, patients should be part of this. Chairman Kenko, I want to ask that any research proposal that we are writing, and we are going to ask our research scientists, because you cannot conduct research as an individual, we should have patient voices. Last year, we had a research meeting in Mombasa, and I wrote to Kenko and I asked, we would like to sponsor 2 people from Kenko to be part of a workshop. And we had representation from Kenko. We are moving forward with that journey, because for sure, you have to be on the table when discussions are being undertaken. I also want to encourage you that we will be your true advocates to make sure you get quality medicine. We would like, even as we struggle towards survivorship, we want you to survive when you are not cursing that I better have died than to suffer complications that are more stressful than when you are alive. Are there some of us who've ever wondered whether that could be an option? because people go through a lot of challenges. If you hear Uncle Zach mention that he lost family, so if you've lost family, I don't want to ask, but what I know is it has not been easy for him. But let's be his family. That's what I told him last time. And those who have joined him as we move forward. Because we have to work together, we have to encourage one another. We will work towards making sure you can access, for those who are going through treatment. I want to encourage Rachel and the team who have come out loudly. And I want to commit that I will do my best to get you to meet the president. I will use the networks that I have to make sure that happens. Because our president is accessible. Haven't you seen every time when he's meeting people in State House? And I know he would be willing to listen to you so that you can tell him what you're going through. All right? So I will work to keep my commitment and communicate through Kenco leadership. I listen to Hope giving us hope. And I see this young girl and I see hope. I see the future. Dr. Nderitu, I think this young girl should be an oncologist in future. She should be hanging around Kenyatta Cancer Treatment Center doing advocacy and encouraging people with poems and songs, right? And we need more of such people. If all of us could do this in the premises where we find ourselves, then I am very certain we will win this battle sooner than we thought. I want to end by asking all of us, whether you've gone through the experience or not, the fact that we are here, then it means we have all committed, we've all sacrificed to stand for each other. We have all created time. We are all using our personal and institutional resources to make sure that we win this battle. Many a times, you have asked that cancer should be declared a national disaster. Many a times, we have asked for practical prevention through regulations. And I want to echo the Ketka and team and Irene at the Taxpayers Association. We have engaged the National Assembly on legislation towards practical cancer prevention, and it is work in progress. In fact, as we speak, we are working with the legal team at the Department of Health National Assembly to craft these legislations to be sponsored by one of the members of the committee. So as you go to the parliament this afternoon, just know we are all together in this. We are all going to make sure that out of the 44,000 patients who are being diagnosed with cancer every year, if they must increase in the short term, it is because of increased diagnosis. But in the long term, the curve should come down. Down, 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 and down. And if one has to be diagnosed, because 70% of those are diagnosed with stage 3, 4 cancer, then let it be stage 1, 2, because of prevention and early diagnosis through screening, who, when they are treated, they will all be surviving, like yourself, this afternoon. That is our wish, and that is our prayer. So I want to, with confidence, again, give you, as survivors, as stakeholders, as partners, those who treat, those who support any of the 5 pillars in our National Cancer Control Strategy, because we are all involved in that we shall work together. And I want to encourage you to work very closely with the National Cancer Institute of Kenya, because we are your voice. There are many things that we do in our communities, but sometimes nobody gets to record and report so that you can also be acknowledged to be an award-winning. How many of us wants to be award-winning? You know, Benda Kilele, congratulations, and Mwalimu as well. I'm sure many of us, their work should be seen, and you should be seen to be making that difference. We will be able to acknowledge and report jointly. The reason why the National Cancer Institute of Kenya was established was to coordinate. So let us coordinate. Let us know how you want to help and how we can help you. As you've heard, our offices are very open, and we are willing to support when we have capacity. Allow me then to wish you a very good afternoon and provide commitment that we are leading in the cancer response, and together we shall win this battle against cancer. May God bless you. Thank you.
Thank you very much, Dr. Meli. We have heard all you have said, and we will hold you to it. We'll be camping at your office so that you can take us to State House.
Karibuni sana wageni wetu, karibuni sana, karibuni sana. Haya, karibuni sana. Alafu tuweze kusomewa, tujue inatuambia nini. 1, 2, 3, makofi. Tolwa si tolwa. Karibu sana mheshimiwa wageni.
Haya, nitasoma. This plaque was unveiled to commemorate Kwale Oncology Center, which was built by the county government of Kwale and officially opened by Her Excellency Fatuma Mohamed Achani, Governor Kwale County. Also in the presence of the Cabinet Secretary for Health from the national government, Madam Deborah Baraza. During the G7 Empowerment Program in Kwale County on Thursday, 17th October 2024. Makofi.
Asanteni sana.
Kwanza ningependa kuwashukuru nyote. Asalamu alaikum. Bwana asifiwe. Mimi nitakuwa tu mfupi kwa sababu chema chajionyesha chenyewe. Hivyo ama sivyo? Oncology tumeiona, tujaiona. Sasa tutatibu saratani tukiwa ndani ya Kwale. Sio ni sawa? Na siku ya leo tumeweza kuhost pia waziri kwa sababu ya uhamasisho wa masuala ya saratani. Na safari ya leo ni ndefu, hatutakuwa na speeches ndefu kwa sababu bado nataka kuonesha dada zangu baadhi ya miradi ambayo tumefanya kama Wakwale. Baadaye tuwe na sherehe pale Kwale Teachers Training College pale Banga. Naomba nichukue fursa hii nimpatie chair wa ODM, National Chair ODM ambaye pia ni gavana wa Homa Bay. Big Gladys Wanga, karibu sana.
Asante sana Gavana Achani, sisi hatuachani na Achani. Na kazi inajionyesha na inaongea. Na saratani inaleta shida sana kwa watu wetu. Na saa zingine lazima utembee mbali uende mpaka Coast PGH kutafuta matibabu. Sasa Gavana Achani ameileta hapa. Ni vizuri ama si vizuri? Vizuri sana. Achani bomba ama si bomba? Bomba. Achani nyalo ama si nyalo? Nyalo. Asante sana.
Watu wetu wa Kwale, asalamu alaykum. Bwana Yesu asifiwe. Sisi tumefurahia sana kuwa hapa na mama Achani. Unajua watu wengi hawawezi kuelewa vile mama amefanya. Wagonjwa wengi wa saratani huwa wanatembea safari ndefu kupata utibabu. Sasa tumeona watu wa Kwale watakuwa wanatibiwa wapi? Hapa. Mama Achani, hiki ni kitu cha maana sana. Hapa wacha nikwambie, ni Mwenyezi Mungu tu atakulipa, kwa sababu wale familia wameshaishi na mtu ako na saratani, wanajua vile maisha inakuwa. Asante sana mama, Mwenyezi Mungu akubariki na uendelee na kufanyia watu wa Kwale kazi ya maana kama hii.
Oncology kama hii itasaidia sana familia, na hamwezi pengine jua umuhimu wa center kama hii until mtu mmoja kwa familia ako na hii shida, na nawaombea kusiwe na mtu mwenye ako nayo, lakini at least akiwa ataweza kutibiwa hapa karibu, hata panda gari kwenda Mombasa kutafuta kutibiwa, si ndio hiyo? Ama Nairobi ama kwingine. Kwa hivyo mimi naweza sema nimefurahia sana maneno ya devolution. Kwa sasa tunaona hata saratani inatibiwa hapa. Unajua mimi ndugu zangu hata sina la kusema. Nikiangalia huu mradi wa mamilioni ya pesa ambayo kaunti imetuletea chini ya uongozi wa mama yetu Mama Fatuma Achani. Kwa kusema ukweli, yule mtu ambaye ashaathirika na gonjwa hili la kansa ndio anaweza kuelewa. Mimi nikiwa pale Nairobi, ninaona wananchi wa Kwale wanapata tabu kuja Nairobi, ukae pale kama siku 14 mpaka siku 21 kupata matibabu. You can imagine zile pesa ambazo wewe unatumia. Mama Achani, sisi wa Kwale hatuna zawadi ya kukupa dadangu, lakini ile kazi vile ambavyo unaifanya mtoto wa kike, unaifanya kwa roho safi. Mwenyezi Mungu peke yake ndio anaona. Kwale hoya! Waswahili wanasema chana chema kulishwa dede, ngala muwe mcheza kwao. Jamani, Achani ametenda hajatenda? Aliena macho waambiwa tazama. Basi miradi ya Mama Achani ni kochokocho. Yaani nikianza kuisema hapa tutachoka miguu. Tutachoka miguu. Ametenda na amefanya oncology center ambayo tulikuwa tunaenda Kenyatta National Hospital Nairobi, lakini leo iko hapa.
Napenda kabla nipeane nafasi tuliwaambie wale ndugu zetu, kwanza leo hii tumefungua hii cancer center, tuweze kuhamasisha wale wengine pia kuwa huduma za saratani sasa zinapatikana ndani ya jimbo hili. Hapa ni nyumbani, hapa tutahudumia kila mtu. Hapa tunao wahudumu ambao tumewapeleka wamejifunza masuala ya saratani. Kwa hivyo cancer center hii iko na wataalamu ambao wamehitimu. Kwa hivyo nawaomba wa Kwale tuweze kuendelea kuhamasishwa, na pia vile tuendelee kupima. Screening inaendelea katika facility zetu zote, kwa hivyo tusisite kwenda kwa screening. Niweze kuchukua opportunity hii kwanza nimshukuru Rais wa Jamhuri ya Kenya ambaye ameweza kutuma waziri wa afya kuja Kwale kuzungumza na Wakwale. Karibu sana waziri.
Asante sana Gavana Achani. Assalamu alaikum. Bwana Yesu asifiwe. Leo tumekuja leo na tumefurahia sana kuona kweli huduma inaletwa mashinani.
na tumefurahia kwa kazi ambayo tumeona. Prevention inaendelea, tumeona mahali ya screening inafanyiwa hapa na madawa pia yako ya kutibu kansa. Sasa tuendelee hivyo na tutaendelea kama ministry kusupport kuendeleza hii cancer center iweze kuwapa huduma nzuri sana. Pia ningependa kuongea juu ya SHA, na tunasema hii Social Health Authority ni muhimu sana. Tunasema to register. Ukiregister unaweza pimwa bure, alafu pia unaweza pata madawa ukitoa tu contribution, na unaona inafika mpaka 400,000. Kansa inakuanga ugonjwa ambayo inafanya watu wanauza mashamba, wanauza mali ndio waweze kupata huduma, lakini ukiregister kwa hii Social Health Authority utaweza kupata huduma. Sasa tunasema wacha tu register, na pia mkuwe screened, wa mama wa baba, kujeni wote mkuwe screened ndiposa mpate tibabu. Asante.
Kwa majina naitwa Veronica Ndambuki. Mimi nashukuru Mungu kwa hii kituo kilichowekwa mahali hapa. Mimi ni mkaaji wa hapa Kwale, na ninashukuru sana kwa hii ushirika ya National Cancer Institute. Waliweza kuja kutuelimisha juu ya kansa na tukafanyiwa check up, na sisi tukashukuru sana, na tunashukuru kwa sababu walituelimisha na tukaelewa, na tulikuwa tumekuja kufanyiwa check up, tukafanyiwa vizuri kwa njia nzuri, na tukawashukuru sana. Kwa hivyo tunashukuru sana kaunti ya Kwale kwa hii mradi waliweka mahali hapa. Mungu awabariki sana kwa kutusaidia, manake tulikuwa tuna mahali pa kwenda, haki ni mbali, na saa hii naona ni hapa, iko hapa Kwale, na watu kweli watakuwa wakija kwa wingi kwa sababu si mbali. Hii Kwale kaunti kufika hapa huwa ni rahisi, si sawa na ikiwa mbali. Kwa hivyo tunashukuru sana. Hata hao walikuja akatuelimisha, na kila mtu tukaelewa, na tukaenda tukaelimisha wengine kule manyumbani na wakaelewa. Kwa hivyo tunashukuru. Hata kama tutakuwa pia tunaomba pia kama inawezekana tufanyiwe bure check up. Kasi hatujui kama itaendelea. Hata kama kutakuwa kuna pesa pia kidogo, tutashukuru Mungu pia, kwa sababu heri upate kuliko kukosa. Kwa hivyo tunasema ni asante.
Hi everyone, my name is Roslyn Okumu, oncology nurse specialist from National Cancer Institute. Today I'm talking to you from Kwale County Oncology Center, where we have been from 14th of October to 20th of October just to create cancer awareness and do public education. So we've been able to meet many clients, and we've talked about breast cancer awareness, cervical cancer, prostate cancer, and the key highlights even to childhood cancer have been shared through our public education. So through this education, members of the county have been able to uptake the screening, which we've been offering here, pre-screening sponsored by the National Cancer Institute in collaboration with Kwale County, and we've had a very good working relationship with the nurses and the doctors here. We've been able to do cervical cancer screening, prostate cancer screening, and breast cancer screening to the ladies, and we've also been able to refer them for mammograms. So thank you very much for taking the information on cancer screening and awareness very seriously, because we know that cancer screening and early detection saves lives. So I would just like to tell you that we've had also great highlights while we've been here. We've had the launch of Oncology Cancer Center of Kwale County, which has been done under the guidance of National Cancer Institute CEO. We've been able to offer technical support to them, and so they have a very nice state-of-the-art cancer center that you can all come and leverage on the services. People of Kwale County, leverage on the services so that you can be treated promptly. Thank you.
The World Cancer Survivors Day, and on tonight's show we celebrate persons who have beat cancer after treatment. We'll also be raising issues around awareness and the existing challenges and the cancer burden in Kenya, which still remains a huge concern. And tonight I'm joined, starting from this end, by Dr. Elias Meli. He's the CEO, National Cancer Institute of Kenya. Many thanks for joining us, Daktari.
Thank you.
We're also joined by Phoebe Ongadi, Executive Director, Kenya Network of Cancer Organizations. Thank you for joining us, Phoebe. And also joined tonight by Sydney Chahonyo, who is a cancer victor or warrior, if you like. Thanks for joining us, Sydney.
Thank you for having me.
Sydney, I'll begin with your story today, this being a celebration of persons that have survived cancer, and of course being very significant for families across the country that have, you know, a family member that may have been diagnosed, as well as persons who are undergoing treatment. So share a bit about your story with us. When were you diagnosed with cancer, and what type of cancer was it, and at what stage?
I was diagnosed with cancer of the postnasal space at the age of 19. This was in 2004. I just finished high school. I was about to, go abroad for further studies. And at that point is when I started getting the symptoms. And it was, by the time I was diagnosed, my oncologist told me that it was very early stage. So I was one of the more fortunate ones.
Right. Okay, so you were told it was, in terms of, and we want to talk about your experience with the diagnosis in terms of how it was communicated to you, fairly young, just straight out of high school, and you're given news that you have this type of cancer, although it's early stages. In terms of the diagnosis and how that was communicated to you, what was your experience with that?
Before I answer that, I'll start with the process of the diagnosis. It took about 6 months to get the correct diagnosis, and this is even going to the best hospitals, the Aga Khans, the Nairobi hospitals. It took about 6 months of misdiagnosis to actually get the proper diagnosis. I remember at the point of being told that I have cancer, I had gone in for a follow-up after doing my biopsy and doing my blood work, and I was sitting there with my dad, and at the point where the doctor said, "You have cancer," my mind just blanked out. Like, I completely don't remember anything else that happened for the rest of that day. But I remember seeing my dad balancing tears in his eyes. And that's the first time I'd ever seen my father looking vulnerable. So at that point, it was a bit of a shock. And as I said, it takes a lot to process it. There's a lot of mental strain that you go through. Start asking yourself questions. What exactly is happening? You almost want to pinch yourself to find out if I'm dreaming or if this is real. It takes a couple of days for you to accept that diagnosis. And also, at the same time, what's going to happen to me? But luckily, my oncologist was also very supportive. And he told me that he had handled cases like that before. It was cancer of the postnasal space, which is where your ear, nose, and throat meet. And apparently, it's very common in East Africa. But he told me that it was caught pretty early, and I had a very good chance.
Sorry for interrupting you. What symptoms were you experiencing?
Initially, just normal symptoms. First, I had flu symptoms, like I had a runny nose. Then I started having very mild headaches at the back of my head. Headaches that you drink water, you take pills, Panadol, what have you, and then also started nose bleeding. But with time, the symptoms got more severe. The headaches were more and more severe. The nose bleeding was more frequent. And that is when I started realizing there was a problem. But also because of where the cancer, the growth was, it was starting to block my hearing passage. So I started losing hearing, and that was actually the trigger for me.
Now, you talked about going through, and I'll get to Daktari and Phoebe shortly, you talked about going through a number of hospital visits before this diagnosis was actually made. In that process, because you talk about having been with your parent, in terms of the post-diagnosis, rather even before the diagnosis, the cost that was involved during that entire experience before you even got into the treatment, did you get a scope of how expensive it was for you as a family to deal with that?
In terms of diagnosis, that was not the most expensive bit of it. Luckily, I did have health insurance. And, I'd go to a hospital, I'd be told you have to do these tests. So I'd do my MRI, I'd do my just normal blood work, I'd do certain tests. Eventually, it started being you need to do a CT scan, which were costing between 8,000 and 20,000 per scan. After that, you do a lot of blood work, and you keep doing this because you go to one doctor, he tells you need to do tests, and he tells you it's a sinus problem, and you say, let me get a second opinion, because you've been through that before, you've been given the pills, and you know it's something different. So you go to somewhere else, and you have to start the process again, because now you have to do another round of blood work. You have to do another scan, because the doctor will only move on scans that he has prescribed or scans that were done at that hospital. So it was a lot of repetitive costs. So I would say, I can't give you a figure off the top of my head, but every time I would see a new doctor within that 6-month period, I'd have to pay consultation fees, the cost of the diagnostic tests, and then also just the moving around. It was also just stressful.
Yeah.
Yes.
Thanks for sharing that, Sidi, and I'll come back to you as we, of course, talk about your journey and where you are at now. Phoebe, in terms of the barriers to cancer care in Kenya, we're talking about how long it took for a diagnosis to actually be made. So in terms of the high rates of misdiagnosis, first of all, that we know have been known to exist, and the inadequate screening hindering early detection. Let's speak into that and how that affects the journey towards survival. As days go, the cancer is advancing. Perhaps when Sydney started going to hospital, like he said, he was told it's early stages. But for other people, they get to find out way later when the cancer is at a very advanced stage.
Thank you very much, Lillian. I think that it's very important to have the conversation of access. And as Sydney has said, is one of the lucky people who got the cancer early enough. But we are having a lot of barriers, like you have said, because when we look at access, we look at access in diagnosis, we look at access in detection, we look at access in treatment and care. We also look at access in all the aspects of cancer treatment and management. So the barriers in access actually are one of the challenges that we were highlighting today during the survivorship, because we are saying, well, we are saying we are celebrating survivorship, but are we really celebrating? The survivors are coming out to tell us that as much as we are surviving, there has been hurdles on the way. What about that person in the village, in unreachable areas, who are not able to access some of these services that maybe Sydney is also talking about? So barrier to early diagnosis, barrier to treatment, barrier to care is a real challenge to cancer survivorship.
Right, and Dr. Elias, still on that and staying on that beat, in terms of the burden of cancer treatment in Kenya, talking about repeat visits even before the biopsy, and now looking at the actual cost of cancer treatment in Kenya and what on average it would cost for even, chemotherapy, give and take. Where are we on that? Because a lot of Kenyans perhaps might not find themselves in a position where they can even afford, the luxury of going through repeat and routine chemotherapy. Others don't have insurance, or it's still hanging, in the balance, give and take. So in terms of cancer treatment and looking at survival rates in the country, before we even talk about people going to India, where are we?
All right. Thank you, Lillian, for having us tonight. And I want to begin by thanking God for those who have been able to breast through the cancer challenge. Today was, according to my understanding, one of the best days that we've had, those of us who are in cancer space for a while now, celebrating the success stories. When you get an opportunity to interact with those who have actually been diagnosed with this terrible disease, and they have gone through, the entire course of treatment, whether it's surgery, whether it's radiation, whether it's chemotherapy, we are really happy that we can have positive stories. For a long time, cancer has been dubbed death sentence. But for once, we had a huge team. We had a real festival. We sang, we danced. We thank God for, the favor and the grace that many, just like Sydney here, have been able to have over time. And going straight into your question, the burden of cancer, of course, in our country is rising. It's no doubt. And it's not only in Kenya, it's a global concern. It is a regional concern. And cost, as you mentioned, is one of the moving parts that influences survivorship. And it has been quite a challenge for most of our people to afford this treatment. And we are looking at cancer care across the entire continuum of care, and beginning with prevention. We are looking at early detection. We are looking at screening. We are looking at real diagnosis using either pathology or imaging and radiology. We are looking at treatment. And for you to treat cancer correctly, currently, unless you are able to go into the details of molecular characterization of cancer so that you do personalized treatment. We are no longer doing general treatment for our patients. If you have, 6 people with breast cancer, it is not the same disease.
Right.
You have to go into the genetic level and be able to characterize so that you can be able to do targeted treatment. We are at an era where it is doing what we are calling genomic characterization, so that we look at what is driving your disease.
Yeah,
and
talking
this is
about
where
genomic characterization, and that's a question that came in when we teased this interview. When we talk about the cost of cancer treatment, we are made to understand that our genes, perhaps African genes and Caucasian genes, are different, and yet when you look at the cost of treatment, still remains the same. Talking about that and the fact that you're saying that this is very individual specific, it still remains a very expensive affair, irrespective of the fact that genes, differ.
Correct, because cancer is a genetic disease. We all know it begins with a mutation. There is an error that occurs in our genes. And our genetic instabilities and our variation in our immunities, the imbalance is what leads to this cell to multiply and ultimately becomes cancer. So if you have to address this challenge, you have to go back to the gene. And as much as we look at the Caucasian and the African population, even within our country, our Kenyans who live in the northern part of the country are different from those who live at the western part of the country. And it's different because there is what we call epigenetics. The environment, where you live and where you grow up, influences a lot on how your genes will look like. And as we approach diagnosis and treatment, we have to be guided by what we call biomarkers. And this is where the real expensive cost of cancer care comes in. And if we are to really work on making sure we increase survivorship, we have to do targeted treatment. We are no longer going to burn the forest to kill, a snake. We have to look for the snake and deal with it and leave the ecosystem. So we have been providing a lot of generalized treatment. If you talk about chemotherapy, when you ask me, Lillian, what is the cost of cancer care? I will not give you an answer. But if you ask me, what is the cost of a 59-year-old who has estrogen positive, breast cancer, then who is stage 3, we can then have a discussion, because then I will be very specific. Otherwise, I would say we have a range. We could say to treat breast cancer is different from cervical cancer, from postnasal space cancer, from brain cancer, from blood cancers, leukemias in children. So we can talk about range.
And we'll continue with that. Phoebe, I want to get back to you before I cross over to Sydney. When you looked at today's celebration and today's festival and looking at the survivors and their stories, what factors played a key role in terms of the better treatment outcomes for the people that you interacted with? And what are some of the issues that, lead to better treatment outcomes for people who might have had an early diagnosis, you're perhaps at stage 1 or stage 2, from the people you interacted with?
Yeah, so from the people we interacted with, what led to better treatment outcomes? Number 1 was family support. So most of them were saying, and that's why as KENCO and civil organizations, we advocate for psychosocial care. And May being a mental health month, we advocate for families and caregivers, because right now, Muli, almost everyone is affected by cancer. It is you are either sick or you know someone very close who is sick. And cancer right now does not look at your age, your background, your education and all that. Yeah. So one of the things they were saying is also the supportive access in the different hospitals that they come to, the caregiver attitudes, the healthcare workers' attitudes, and also the availability. And I think it's a reason to appreciate this government for especially the strides with the help of the civil societies, organizations like Kenco and the rest, there has been really a progressive improvement even in the coverage of health insurance for these patients. So one of them is, which is currently under review, and we have had a sneak peek of it. It's better with the chronic illness care for the cancer patients. And so those are some of the reasons, because as you say, Lilian Muli, if you have a friend today with cancer, in a matter of time, you will find yourself in a WhatsApp group. But the survivors came out very strongly and saying, no, we have hospitals in this country, we have referrals in this country, they are actually treating cancer, there is no need to travel out. So the message that was there today was, there is hope. And if you look at statistics, like Dr. Meli was saying, you wouldn't find statistics on survivorship. You'll find the cancer burden, the new diagnosis, the yearly deaths. You'll find the devastating news. But there is a lot of survivorship out there. So the message that went out today was the message of hope and message of access, of family involvement, community involvement, and most of all, government involvement.
Thanks for that. Sydney, let's talk about your treatment journey and the involvement of family, the psychosocial support as well as the attitude of the caregivers. Share with us, first of all, were you treated here locally? Did you have to seek medical attention outside the country?
I did all of my treatment here in Kenya. I was treated at Nairobi Hospital. I started first with radiotherapy, and I did about, I would go Monday to Friday for about 4 months. And, you know, it's like getting an x-ray. So they put you in the machine, they target it, and they give you the therapy. So I did that for about 4 months. Initially, I didn't see any changes. But after about the third week, you start getting some of these side effects of the treatment. A lot of pressure on the brain, which eventually led to a point where I was just throwing up. You know, until there's nothing left in your stomach, but you're still trying to bring something up. Aside from that, I had a very sensitive throat. Because of where the radiotherapy was being delivered, at some point it was hard to swallow water. Aside from that, I had some of the other symptoms include my taste buds. My taste buds were completely, at some point I couldn't taste any food. My saliva glands were also affected. So first of all, you're nauseous. You can't taste food. The smell of food even just makes you want to throw up. Even when you swallow the food, you have to have a bottle of water because it's very painful. Even yawning was painful. So those are some of the things I experienced with radiotherapy. And until now, it's still not 100%. After that, I did chemotherapy. And I would be admitted from between Monday and Wednesday to get my drug, carboplatin. I remember my chemotherapy drug. It was called carboplatin. And at that point, it even reached a point where we couldn't find it in Kenya. We looked everywhere, we couldn't find it. We looked in the US, we looked in the UK, eventually we found it in Dubai. And by the time we found it, one vial was going for 50,000 shillings. This is in 2004. So I did my chemotherapy. And what would happen is after the 3 weeks, after the 1 week of being admitted in the hospital, I would be sent home because if they keep giving you the chemotherapy, it's toxic, so it can poison you. Right. So I would need 3 weeks to recover from that bout of chemo. After 3 weeks, I would come and do some tests to see whether my body is strong enough to take the next bout. So after the 5th bout of chemo, I went and did my tests to see whether I could, continue with chemo before figuring out what's the next treatment modality. But at that point, the doctor told me there's no sign of cancer in your body.
So how long has it been now, and do you look fine, you look and we celebrate you today, and thank you so much for sharing your story. How long has it been now? Do you still go for routine checkups? Do you still have to, visit your oncologist every once in a while to check that everything is still okay?
In December last year, actually in November last year, I celebrated 19 years of being cancer-free. So I've been cancer-free for 19 years. Initially, just after you're declared cancer-free, I started going in every 3 months to have my checks just to make sure that it's not going to come back or that they had, gotten everything. After a while, you start going every 6 months. Then after about 5 years, you start going every year. So even now, every year, I still have to do my checks. I'll go in and I'll do my blood work. I'll do various tests. Then I'll go and see my oncologist just to make sure that everything is okay.
Yeah.
Yes.
Thank you for that. Dr. Elias, before we take a break, we want to talk about remission. This debate has been quite rife in terms of, survivors celebrating years and years of being cancer-free. and then, you know, the unfortunate stories of persons who unfortunately have gone into remission before we take a break?
Well, thank you very much. I'm really happy that we are living at a time when our survivors can speak and give hope to those who have been diagnosed, who are still on treatment, that ultimately there is a possibility that they can be treated with curative intention.
Yeah.
Now, complete remission is a hot topic. A lot of patients would be excited after, you know, they complete their treatment. We are now providing, of course, an hybrid guided by biomarkers, as I mentioned, for diagnosis and for treatment. We are able to provide, whether it's surgery, systemic treatment, chemotherapy. We even have now the latest kid in the block called immunotherapy. We are modulating the immunity so that it can fight against the cancer cells. And this is where this, you know, discussions about vaccination comes in. How do we then? There are those who get surgery. There are those who get multimodality treatment. And after that, they are excited with their first imaging after 3 months or 6 months when they go back for review with their oncologist. And I face this all the time. And, you know, we treat patients based on, you know, evidence-based practice. You know, it's not witchcraft. It is protocols that are being used have undergone, you know, intense research to confirm that if you are going to get this combined treatment, you know, the chances of you going into complete remission is ABCD. And we are always excited when you get that first MRI, that first PET CT scan, that first CT scan or an ultrasound. And we are all happy that finally the disease disappeared. But wait until, unfortunately, 2 years, 3 years into follow-up, a patient presents with back pain. You know, some headache, maybe a cough. And of course, we would want at that point to consider, you know, re-imaging. And it's always quite unfortunate when we disclose that the disease could have recurred.
And that's what Phoebe was talking about in terms of caregivers' attitudes. Cancer has gone into remission, but in terms of the follow-up of the caregivers, the oncologists, and checking up on their patients, and you talked about the involvement of stakeholders, the Ministry of Health in terms of trainings, and what have you, Phoebe, talked about that. But in terms of the follow-up, you know, of patients, you find patients perhaps having to move from one oncologist to another because one oncologist said that you're in remission. You know, he's found that, you know, you're at a good space now. But then again, years later, you know, perhaps something happens and you're thinking, this oncologist said that I had gone into remission, hasn't followed up on what's going on with me, or at least there hasn't been that patient doctor, you know.
So I think it's a valid concern. And from time to time, when I sit in the clinic and I'm guiding my patients after completing treatment on a follow-up plan, we have to make sure that these patients adhere to the follow-up plans. The first year is always after every 3 months, and you should come back and see your oncologist. But the challenge is the excitement of that first imaging that I am in remission. But the language and the communication that I really want to pass across to those who have undergone treatment, complete remission can only be concluded to cure after at least 5 years of follow-up. It is very important for us to know that. It's not with the first imaging, because, you know, there are many factors that influence prognosis. As we mentioned, you did ask Lillian earlier on about factors that influence survival. We talked about cost as one of them. You know, there is patient-related factors and there is disease-related factors, that all of them must be favorable for a patient to go through treatment with expectations of cure. So at this point in time, because we really want to give hope that, yes, it is possible to go through treatment, but we have to be careful. You know, as we, you know, hope for the best, we should also prepare for the worst, just in case there is a possibility of recurrence. And still give hope that even if there is a recurrence, there is still a possibility that you can be treated with still curative intention. I would use an example of ovarian cancer. You know, from statistics, from data, you know, using the conventional treatment that we are able to provide right now, ovarian cancer is one disease that responds to treatment. After debulking surgery or after surgery, and you consider chemotherapy, it melts away.
Yeah.
But more often than not, more than 50% of them would recur. And of the 50%, if you subject to treatment, if it's been beyond 6 months, after treatment, you can still treat them with curative intention. So the emphasis that we're giving here this evening to those who are undergoing treatment, that they should adhere to their follow-up plan. And I want to ask that we should trust the healthcare providers, the cancer specialists who are within our hospitals, whether public or private, because we have built so much capacity now in our institutions that we should be able to trust that we can undergo treatment in this country with curative intention, and we should go into survivorship. All that we are asking is, please, if you are asked to come for a follow-up, make sure you come. We have a lot of patients who get lost to follow-up, and that's where there is a huge challenge. We conducted a study in Moi Teaching and Referral Hospital on children, and we found out that loss to follow-up was contributing approximately 23% of mortalities.
But that could also be an issue of the distance and the access that Phoebe was talking about. If you have to leave far-flung areas to come all the way to the Kenyatta University Teaching and Referral Hospital, to see your oncologist, then surely follow-up would be compromised.
And that is why, as a country, we are increasing capacity across our counties. And if we cannot provide a comprehensive cancer treatment center in every county, we are now setting up regional cancer treatment centers so that these patients do not have to leave Mandera or Busia or Migori to come to Nairobi.
Right.
They should be able to get care close home.
We'll be continuing with our conversation with our panelists. Remember, we are celebrating cancer victors, people that have beat cancer after undergoing successful treatment. And we are also very keen to know from our viewers why the rush to India. What is the rush to India all about? Do we trust our institutions here in the country? We'll be continuing.
There is an error that occurs in our genes, and our genetic instabilities and our variation in our immunities, the imbalance is what leads to this cell to multiply and ultimately becomes cancer. So if you have to address this challenge, you have to go back to the gene. And as much as we look at the Caucasian and the African population, even within our country, our Kenyans who live in the northern part of the country are different from those who live at the western part of the country. And it's different because there is what we call epigenetics. The environment, where you live and where you grow up, influences a lot on how your genes will look like. And as we approach diagnosis and treatment, we have to be guided by what we call biomarkers. And this is where the real expensive cost of cancer care comes in. And I want to ask that we should trust, the healthcare providers, the cancer specialists who are within our hospitals, whether public or private, because we have built so much capacity now in our institutions that we should be able to trust that we can undergo treatment in this country with curative intention, and we should go into survivorship. All that we are asking is, please, if you are asked to come for a follow-up, make sure you come. We have a lot of patients who get lost to follow-up, and that's where there is a huge challenge. We conducted a study in Moi Teaching and Referral Hospital on children, and we found out that loss to follow-up was contributing approximately 23% of mortalities.
But that could also be an issue of the distance and the access that Phoebe was talking about. If you have to leave far-flung areas to come all the way to the Kenyatta University Teaching and Referral Hospital, to see your oncologist, then surely follow-up would be compromised.
And that is why, as a country, we are increasing capacity across our counties. And if we cannot provide a comprehensive cancer treatment center in every county, we are now setting up regional cancer treatment centers so that these patients do not have to leave Mandera or Busia or Migori to come to Nairobi.
Right.
They should be able to get care close home. So we want together, jointly, work as a team and point our arrows forward on addressing these challenges. So we have also a responsibility towards building partnerships and resource mobilizations as one of our functions. And we are leading the efforts of mobilizing resources domestically through National Assembly for Cancer, and we are also mobilizing privately through the partners, both locally and international community. Last, I think 3 or 4 months ago, Mheshimiwa, we had a meeting with the chairpersons of all county health assemblies. And the reason we had a meeting in Naivasha from all the 47 counties, because we also acknowledge that counties have health budgets. And Dr. Waome, as you plan, cancer had been a neglected disease for a long time. But if we honestly are appreciating that cancer is one disease that is posing the biggest burden, then we should also allocate the most resources. During the corridors and the streets and media houses, when the finance bill was being discussed, even when the Gen Zs came to the streets, cancer was mentioned evidently from the leadership in the country that we need this finance bill so that we are able to finance through Social Health Authority, cancer. While on the other side, the Gen Zs were saying, you are taxing a lot, including taxing cancer drugs. So everybody had, an interest towards making sure the cancer agenda is moving forward. So I did have an in-depth discussion with chairpersons of health committees at the county assemblies, and they appreciated that we are one of the first state corporations to call county assemblies to discuss matters that are of interest. And I want to believe you will continue advancing that cause while you will be discussing on your county budgets. And Dr. Waome, you can insist with your colleague at the executive that we get more allocation to cancer from the county, so that as we support, you have also demonstrated goodwill at home, right? Yeah. So it is important. Our other function is advocacy to make sure there is adequate financing for cancer. So working with Social Health Authority, we participated heavily to take care of the interest of cancer in the 3 funds, and I'm glad the court extended the stay order yesterday to allow us at Ministry of Health to still provide evidence and legitimize why we need all the 3 laws, because one of them is Social Health Insurance Act, which then creates for Social Health Authority to exist. Because we do agree that it's better than NHIF, because NHIF is just equivalent to SHIF, which was one fund, but then now we have Primary Healthcare Fund, and we have Chronic Disease, Critical Illness, and Emergency Fund, which is an addition, and there is so much that addresses cancer issues, both at the Primary Healthcare Fund on screening. We are currently, maybe from Dr. Leah, I do not know how active your histopathology department is at the Meru County Referral Hospital. We are also working on building more capacity at the National Cancer Reference Laboratory in Nairobi to support counties that do not have diagnostic capacity, where specimen can be sent to Nairobi. And for a long time, our laboratory has not been optimized. But right now, we have put in efforts to make sure that if you lack pathology services, if you lack, analysis of specimen, and even as we work towards conducting research in the community, we may consider specimen that we are collecting from the community, either from, soil, from water, from human subjects, and we need to analyze them. So we have to provide mechanisms of making sure we can analyze this data. So we do provide a lot of advocacy to make sure our patients are financially protected. It is expensive to treat cancer, we agree. Social Health Authority provides, in fact, the winners. If we are able to finance the entire SHA, the greatest winners are those patients who are diagnosed with cancer. But then we don't want them to be diagnosed with cancer. We want to prevent, and we want them to be diagnosed early, where if an opportunity presents itself, they can even be treated, you know, when it's precancerous. You know, and if it's cancer, it be stage 1 or 2 that can be treated with surgery alone. Or if we must include chemotherapy and radiotherapy, then those services should be available so that we can improve treatment for our patients, we can reduce morbidity and mortality, and we can increase productivity economic-wise in our communities. Our children to go to school, families to have food, because I have faced real realities where a patient asks you, I do not have money to come to the hospital. I don't have transport. And that then means I don't have food. My children have dropped off school. Very sad, you know, picture. Social Health Authority would address this. We also have an opportunity from the National Cancer Institute of Kenya to build capacity in oncology workforce. This year, we have committed some little resources towards competitively sponsoring a few healthcare workers. And many a times, I have refused to believe that cancer care can only be better because we have an oncologist. We need a whole team. A whole team. Those guys who are in a multidisciplinary tumor board, we are more than 20 of us in that board. And we need to build capacity, either curriculum-based or non-curriculum-based in all those healthcare workers. So we shall soon be sending out an advert for application. And we are going to vet competitively, just like we will be sending out a call for cancer research. And all of us will be free to apply. Vetting is very open. We are going to guide on what thematic areas we want, you know, for us to focus. We are really interested in making sure we turn around the cancer agenda in this country, because that is why we exist. We do not have another job. You know, if you ask Dr. Wawome here and our County Director of Health here, you have so many things to deal with beyond cancer. I sympathize with you guys. If we have challenges and we are dealing with one disease, I want to believe you have more problems than I do. But we wish you well as you address them. All right? Finally, we have a responsibility to protect the rights of those who are diagnosed with cancer. Okay? Because treatment of patients with cancer, either complications from the disease or complications from treatment, whether it's chemotherapy, surgery, or radiation, or they can be debilitating. And sometimes these patients face a lot of challenges. We had a recruitment at the National Cancer Institute in the past couple of months. And among applicants were patients diagnosed with cancer. And we actually gave them an opportunity to be part of the staff, because then they will make us at the institutional level appreciate from a personal experience what we should be doing. But then there are many people who are out there looking for jobs, and sometimes they are sent away by virtue of having been diagnosed with cancer. There are some who are denied opportunities in education. You can't sit for exams, you are not in class. You know, there are some who are denied even credit, that facilities, that you have cancer, because people have stigmatized that you will die before you pay our loan. So we have to stand out and make sure we protect, you know, even issues to do with disability, we are able to provide guidance. All right? So I want to summarize from our functions at that point in the interest of time. I thought it's important to engage you from that perspective so that you can understand our role, because I know there are people who today probably they are hearing of National Cancer Institute of Kenya for the first time. There are some who have heard, but they were not very sure. What does it do exactly? There are some who are wondering, you know, how then can we benefit from this institution? So it was important to mention that, so that even as we now listen to you briefly on what are your priorities as Meru County, where we can partner and work together, then you know what we are able to offer. All right? So allow me to end at that point, as I continue to appreciate an opportunity to engage you, to discuss with you. And I had mentioned earlier on that we serve under the oversight of a board of trustees, and our chair of the board is Dr. Githinji Gitai. He is a key personality in the health space in this country, regionally and globally. We have the opportunity to have 9 other board of trustees, where Dr. Gadere is one of them. And we have governance structures in the institution to make sure we are able to provide services as per the guidance of the law. So thank you very much for creating time to listen to us. We are here to jointly solve a challenge that is a priority to all of us in the offices that we serve. Asante sana.
Thank you. Let's give applause.
Nilikuwa na stage 3C breast cancer na nilikuwa diagnosed 1st of August 2022 na nikatibiwa hapo KU miezi 12 mpaka August 2023 tarehe 3 ndio daktari akasema ile ugonjwa imeisha kwa mwili yangu. Leo sana nataka kuongelesha watu wa hapa kwa sababu najua kuna kitu watu hawajui juu ya kansa, na ile watu wanaambiana huko kwa vijiji zetu ya kwamba kansa ni ugonjwa. Sana huko kwetu Meru tunatoka, watu wanasema kansa ni laana, kansa ni uchawi, maneno mingi, lakini mimi leo niko hapa kuambia kansa si laana, kansa si uchawi. Tafadhali ukipatikana na kansa enda hospitali, sikiza vile daktari anakuambia, na pia we mwenyewe ujipende ndio uweze kupona. Lakini sana tusikize maneno ile daktari wanatuambia, kwa sababu wale ndio expert ama wale ndio wanajua hiyo shinda. Kansa haitibiwi na herbs. Kansa inatibiwa na kitu inaitwa chemotherapy. Why? Cancer is a lethal disease. Chemotherapy is lethal. Kwa hivyo tunasema it's bullet for bullet. Enda hospitali. Kuna aina 3 ya matibabu. Kama mimi nilienda aina 5. Kuna ile kitu inaitwa mastectomy, kama ni matiti iko na shinda inatolewa. Unafanywa kitu inaitwa chemotherapy. Kuna kitu inaitwa radiotherapy. Kuna kitu inaitwa hormone therapy. Na kuna kitu inaitwa reconstruction, ama daktari siku hizi sana wakitoa hiyo matiti tena wanarudi wanaweka zingine. Kwa hivyo tufuatilie sana maneno ya zile daktari wanatuambia. Kitu kingine nataka kuasisi sana watu wa Kirinyaga ni hiyo mnasikia sasa tuna transit from NHIF to universal health cover. Tafadhali make sure sana watu wa jua kali uko na hiyo card. Serikali yetu inapatiana a very good package ya hiyo cancer. Mimi ni beneficiary wa hii program kwa sababu matibabu yangu yote mpaka wa leo, zile dawa na kunywa kwa miezi 10, serikali yetu ndiyo inalipa kila kitu. Kwa hivyo hakikisha kwamba kadi yako uko nayo inalipwa. Usingoje ile siku unangojeka ndio tuanze kuform WhatsApp, kwa sababu hiyo kitu haisaidii watu sana. Make sure mko na kadi na kadi zinalipwa. Hata kama wewe ni mtu wa jua kali, hiyo kadi yako make sure uko registered, watoto wako wako hapo na wewe unailipia. Kitu kingine nataka sana kuasi, ile malasi yetu ama ile vitu tunakula iko na shinda sana. Lazima tupunguze maneno ya pombe, maneno ya sigara. And for mature people ama wale grown ups, kuna kitu inaitwa multiple sexual partners. Sababu hiyo kitu pia inatuletea shinda sana kwa sababu ya cervical cancer. Pia kuna kitu inaitwa diet, ile malasi. Lazima watu wapunguze vitu kama sukari, fine carbohydrates, vitu kama maziwa lazima upunguze, vitu kama mafuta ile ya kupikia, vitu kama processed food, kwa sababu zile cancer cells kuna kitu inakula kwa mwili yetu, na hiyo kitu inaitwa sugars. Kitu ingine pia ni lazima mkunywe maji. Maji iko kila mahali, kila mmoja wetu hapa kwenu kuna maji. Maji lazima tukunywe kwa sababu maji inasaidia kutoa uchafu kwa mwili, na ile uchafu ikikaa sana kwa mwili ndio inaleta pia shida. Glasi 6 to glasi 8 za maji inahitajika kwa mwanadamu wa kawaida. Kitu ingine ni kujikaza kukula matunda na mboga. Sana sana kwako kusikose kitu inaitwa ndimu ama lemon. Hiyo ni matunda mzuri sana, na vitu zingine mingi, lakini sana sana hizo risk factors lazima tutie. Kama sisi wenyewe tuseme tutaachana na hiyo maneno, kwa sababu hii mwili tu ndio tunaishi nayo. Ya mwisho, mimi na rafiki zangu venye nilipona, tuko na NGO, an international NGO registered inaitwa Nindi Cancer Health Initiative. Tunafanya nini na hiyo NGO? Tunasaidia wale watu wote in the country ama in our country, wale wagonjwa wote wa cancer wametoka kwa familia zile zimefinyiliwa na kifedha, kwa sababu nakuta kwanza kwa vijiji zetu watu ni wagonjwa wa cancer. Mtu anaenda anakuwa diagnosed na breast cancer ama stomach, cervical, anakaa nyumbani kwa sababu ile familia haiwezi kujilipia hata hiyo NHIF for now. So tunachukua wale wagonjwa, tunawalipia miaka 2 hiyo card, ndio mtu aweze kufanywa ile chemotherapy, radiotherapy, kama kuna surgery, hiyo hormone therapy na matibabu zingine na ile card. Kwa hivyo tafadhali watu wetu, watu wasikufie nyumbani na ile ugonjwa, hii organization ikiwa hapa. Kitu kingine tunafanya ya maana sana, wale wa mama wote wamepoteza matiti zao na kitu inaitwa breast cancer, umekatwa matiti kwa sababu ya breast cancer, tunapatiana prosthesis breasts ama tunaziita crocheted breast. Tunawapatia free of charge. Usiweke matambara kwa matiti yako, kujia matiti pale, na ni kitu simple ya kumaintain, kwa sababu hata mimi ndio nimevaa. So tukujia pale hizo matiti, usiende nyumbani bila hiyo kitu, just in case, ama kama unajua jirani amepoteza hiyo kitu. Asanteni sana.
Thank you very much, Chair. European Hematology Association President, President Aortic, President Kesho, Chair Shah, Chair NCI, CEO NCI, local and world leaders, including Professor Abinya, who was my mentor and the father of oncology, taught me through bachelor's degree, master's degree. Good morning. It is an honor to address this Kenya International Cancer Conference theme, Advancing Cancer Care in a Rapidly Changing World. This event provides an opportunity to celebrate our progress, reflecting on existing gaps, and reimagine the future of cancer care through robust policy shifts and collaborative efforts. Cancer has indeed become a critical public health concern in Kenya, with global trends ranking it as the leading cause of morbidity and mortality. Beyond the statistics, cancer impacts resonates deeply in households, communities, and the world at large. In Kenya, cancer is the 3rd leading cause of death and the 2nd among non-communicable diseases following cardiovascular conditions. The annual incidence stands at 44,726 cases, with 29,317 resulting in mortality. These figures call for a concerted effort for mitigation. The government of Kenya is committed to ensuring that every cancer patient can access quality care, including emergency services. The Ministry of Health is enhancing institutional frameworks, human resource capacity, technology, medical products, and infrastructure in line with global best practices. Achieving this requires collaboration of all stakeholders across the cancer care continuum. I want to thank Kesho for its invaluable support in service delivery and strategic interventions in resource mobilization. Through the National Cancer Institute, partnership has been strengthened to decentralize cancer services, bringing them closer to the communities in need. Our cervical cancer screening program through HPV testing, visual inspection with acetic acid have gained traction. Public education campaigns and community-based initiatives promote awareness of cancer, risk factors, and early diagnosis. Community health promoters trained in cancer prevention and control play a pivotal role in this effort. And so I want to urge all stakeholders to integrate their services into ongoing cancer programs. Equally recognizing disparities in access to care, we are establishing regional cancer centers to decongest national referral facilities such as Kenyatta National Hospital, Moi Teaching Referral, and Kenyatta University. We have operational centers in Nakuru, Mombasa, and Garissa, and will soon be joined by additional centers in Kisumu, Kakamega, Meru, and Nyeri. These facilities represent our commitment to decentralizing care while acknowledging the critical role of county governments. We are leveraging on public-private partnership to acquire advanced radiotherapy equipment and subsidize chemotherapy drugs. We hope to meet the local manufacturers and see how we can also subsidize these medications under the Social Health Authority so that our patients can equally access the very same care that we are talking about. Under UHC initiative, the inclusion of essential cancer care packages in the Social Health Insurance Fund is reducing the financial burden on families. We have the prevention by the community health promoters, screening and prevention activities, management, as well as rehabilitative practices, as well as palliative care. However, challenges persist, particularly in workforce development. The limited number of oncologists, pathologists, oncology nurses, and other specialists remain a pressing issue. Local and international academic programs are building capacity, and I want to commend Kesho for its role in professional development through CPDs, CMEs, and training courses. And the ministry, through the NCI, again, is establishing a national cancer research and referral lab to enhance patient care and enable clinical trials. We encourage you to leverage on this. Let us have more data-driven management and also data-driven prevention practices within our community. Addressing data gap is critical. The National Cancer Registry, though operational, requires continuous updates, expanded coverage, and integration with counting systems. Accurate data will inform planning, research, evidence-based care. And I want to encourage Kesho members to utilize this data to advance patient care research while supporting precision oncology. Financing remains a cornerstone of our cancer control strategy, and the ministry is adopting innovative financing models to support screening, diagnosis, treatment, palliative care, and survivorship programs. This mixed financing approach complements SHA funding to ensure sustainability. We continue to engage with global and regional partners, including WHO, USAID, IRC, and IAEA, while learning from initiatives such as the American Cancer Society's patient navigation pilot at Kenyatta National Hospital, and we hope such programs can be scaled up nationally. And so I call upon all stakeholders, cancer specialists, policymakers, clinicians, researchers, industry players, and development partners to reaffirm their commitment to cancer prevention and control. And together we can build resilient health systems, foster innovation, and ensure equitable access to care. Let us envision a cancer-free Kenya, united in purpose and action, and I pledge the ministry's unwavering support for all initiatives. Thank you, and may God bless you all.
And I'd like to welcome the CEO of National Cancer Institute of Kenya, Dr. Elias Meli, to give us his address. Karibu Daktari.
Your Excellency, the Governor Kisumu County, First Lady Kisumu County, our CEC Health Kisumu County, Kesho Leadership, President Dr. Helena Musau, and all the leaders represented in this meeting, colleagues and friends, good morning. Yeah, I'm honored to stand before you this morning as we meet gathered here within the country, in the region and internationally during this Kenya International Cancer Conference. We are delighted that we are making milestones in our country, and we are influencing a lot that happens within the region and even internationally. And Kenya, through the Ministry of Health, has become a light to many other countries. The Ministry of Health is very committed in addressing all the health challenges in this country as it is a right guided by our Constitution. And specifically for reference to this meeting, we know the rising burden of cancer in our country is quite a challenge to each one of us individually and collectively. And we really want to appreciate the role which partners have played in reducing this burden. I wish to congratulate Kesho for the leadership they've provided towards achieving their vision in making sure we build capacity, we provide care, and we conduct research in our country that is going to address the challenges that we have. We know there are so many disparities in cancer care in our country, but we have made a lot of strides this far. I cannot sit down before acknowledging the milestones that this country has achieved, beginning with establishing the National Cancer Institute of Kenya, that is the implementing agency under Ministry of Health.
The leadership that is required to be able to make a difference in this sector. And I think, especially for patients, we always have to remember that at the end of any decisions we make, whether you're a clinician, whether you're a healthcare financer, whether you're somebody who is making other policy decisions like those of us who are sitting on boards of institutions that make a difference, we always have to remember that at the end of that decision, there's a patient, there's a life, there's a family whom we impact. And if we always have that in mind, I think it'll be a moral compass in terms of helping us make the right decisions. So that is one thing we also always need to bear in mind. And those who are patient advocates, this is the only time when noise is a good thing. Any time when we're advocating for patient care, for me that is going to be a joyful noise. So we must continue to advocate for our patients. And there are a lot of things that policymakers might not, some unintended consequences of decisions that people might not realize. And even in our system, as things become more efficient, for example, when you start providing treatment and it's being financed, one of the things I'm very passionate about is let us not make the cure for the disease more painful than the endurance of the same. There are times when we must admit patients are put on treatments that are inappropriate. So there are times when you've got patients who have reached the end of their life, and there is a time when we have to admit that the end of life has come, as opposed to making people incur expenses. There was a study that was done many years ago, and it showed actually that it's not, people assume that with advancing age you have got increased expenditure in terms of healthcare expenses. But that study showed that it's actually dying that is expensive. All right? And dying is expensive because a lot of our patients, especially in this country, they spend 90% of their entire lifetime health expenditure in the last few weeks of their lives. There has to be something there that we need to speak to, because it might very well mean that we're deploying resources where we're not getting value. And worse still, there are times we are deploying resources and diminishing the quality of people's lives at the end of their lives when the focus needs to shift to other things as opposed to clinical treatment. So with those few remarks, I'd like to welcome the Cabinet Secretary to share with us our words of wisdom for today. Thank you very much.
My name is Dr. Michelle Ngu from the National Cancer Institute of Kenya. I just want to retaliate everything that you've spoken about. We have created awareness about cervical cancer. It's 100% preventable. So my call to action for all of you is we adopt the one woman, one community at a time. All of you have sisters, you have wives, you have nieces, you have daughters. So daughters who fit in the age group 9 to 14 years, kindly avail them for the free HPV vaccination in all our public centers. For women, they can be screened. So kindly encourage our women within the recommended age group to come for the free cervical cancer screening, and also encourage the people who are at home, who are afraid of actually the screening because they say it's uncomfortable, the stigma. Right now we are availing self-collecting kits, self-sampling kits, so we are also keeping the dignity of the women in check as we encourage them to come for this cervical cancer screening.
Hi, I'm Dr. Scarlett Nazarian. I'm a surgeon working in London, and I'm here to tell you about the signs and symptoms of breast cancer. Breast cancer can affect anyone at any age. The first symptom that most people recognise is a breast lump or thickening in the breast, armpit, or area up to the collarbone. However, not all breast lumps are cancerous. They can be breast infections or breast cysts. But if you do feel a breast lump or thickening in your breast, then please see your doctor. What are the signs and symptoms of breast cancer? You should see a GP if you notice any of the following: a new lump or area of thickened tissue in either breast that was not there before, a change in the size or shape of one or both breasts, a discharge of fluid from either of your nipples, a lump or swelling in either of your armpits, a change in the look or feel of your skin, such as puckering or dimpling, a rash or redness, a rash like eczema, crusting, scaly or itchy skin or redness on or around your nipple, a change in the appearance of your nipple, such as becoming sunken into your breast. How do you check your breasts? It's really important to check your breasts regularly. There's no right or wrong way. Just check your breasts in a way that works for you. Knowing your breasts and what's normal for you could save your life. So, get yourself a mirror and stand in front of it with both hands above your hips in a superhero pose. Have a look in the mirror for any changes in your breast that you can see. Any skin dimpling, puckering, any rashes or lumps and bumps that are visible. Next, take one hand and feel under the opposite armpit. Have a feel for any lumps or bumps. Do the same thing with your other hand. Once you've done that, pop both hands behind your head. Now, have a look again for any lumps, bumps that are visible, skin changes, and so on. Then, using one hand, feel the opposite breast in a circular motion, ending with your nipple. Feel carefully for any lumps, bumps, skin changes, or pain. Next, use your other hand to do the same. Once you've done that, you're all done. You've checked your breasts.
So this is our mobile laboratory for Cure Cervical Cancer Organization. It's a solar-powered mobile lab. It means that we don't use electricity. We're only using the solar panels. They are up here, and the solar batteries. We have 2 PCR systems, as you can see, from Matilda company. Each one of these machines is able to run 94 samples at a go. So in a normal day, we are able to run around 700 samples per day.
700 samples?
Yes, in a normal day, a very normal day. Yes, we are able to run 700 samples. Yeah, so the good news is that the lab is certified by Kenyans. We are recognized by the government. We have also been enrolled in the national HPV PT scheme, proficiency testing scheme. We are part of it, so we receive samples from them, and the good news is that we have been able to pass the proficiency testing for our lab here. We also have a number of things, as you can be able to see. There is we have here fridge and also freezer. This is where we keep our reagents temporarily when we are working in the field. Very nice sample segregation and sample waste disposal. We have a very good hand washing place, this area. As you can see, there's a hand washing area on the other side.
So ladies and gentlemen, it gives me great pleasure to launch our Cervical Cancer Awareness Month and the HPV screening.
Ladies and gentlemen, wapi makofi tafadhali. Wapi makofi. Oh yes indeed. The official launch of HPV awareness campaign has been officially launched. Siku ya leo, Mr. Kasirilis, naomba tafadhali. Dr. Kasirilis also, please. Kasirilis, samahani. Karibu.
So ladies and gentlemen, it gives me great pleasure to launch our Cervical Cancer Awareness Month and the HPV screening.
Ladies and gentlemen, wapi makofi tafadhali. Wapi makofi. Oh yes indeed. The official launch of HPV awareness campaign has been officially launched. Siku ya leo.
Karibu waziri.
Asante sana. Watoto, Bwana Yesu asifiwe. Bwana Yesu asifiwe tena. God is good and all the time. Thank you. Yes, DG, women rep, all protocols observed. Good morning. I hope it's still morning. Now before, it's afternoon already.
Before I make my remarks, maybe I would want to have the CEO of the National Cancer Institute and the Chair of National Cancer Institute also to give remarks.
Waziri wetu wa afya Daktari Deborah Barasa, Chairman wa National Cancer Institute of Kenya, uongozi wa Samburu Government, tukiongozwa na Deputy Governor, Women Rep yangu Mheshimiwa Pauline, uongozi wa Administration, County Commissioner, uongozi wa Education hapa, walimu pamoja na wanafunzi. Hamjambo? Hebu tusalamiane hewani namna hii. Asante sana. Mumefurahi leo tumefika Samburu? Wageni ambao wanatoka kule Nairobi katika Wizara ya Afya, na tunaongozwa na kiongozi wetu mkuu katika nchi nzima. Amefika hapa leo kwa sababu anawapenda, anajali watoto wetu, anajali wakazi wa Samburu County. Na tumekuja tu tukiwaletea habari ya afya njema. Hata ingawa leo hapa shuleni tumefanya tu exercise kidogo ya mambo ya vaccination ya wasichana wetu, zaidi kwa sababu waziri yako hapa na yeye anaongoza wizara mzima, angependa kuhakikisha kuwa jinsi anaomba Wakenya wote waweze kuwa na afya njema, nanyi pia watu wa Samburu, watoto wetu pamoja na walimu pamoja na wale wakazi ambao wako hapa. Ni furaha yetu. Yangu tu ni kuhamasisha. Mimi ni CEO wa National Cancer Institute of Kenya. Mimi ni daktari, nimetibu watu wengi ambao wako na shida ya saratani, na tungependa kukinga ili tusitibu tena siku nyingine. Hiyo ndio services tumewaletea hapa leo. Na zaidi ya hayo, Samburu County tunaijali kama counties zingine zote 47 katika nchi yetu. Hiyo ndio sababu unaona hata waziri amefika hapa leo, si ndio? Mawaziri wangapi wa afya wamefika hapa Suguta? Ni wangapi? Hamujawahi ona hata mmoja, si ndio? Sasa si mnaona vile waziri anawapenda. Akasema lazima mimi mwenyewe afike hapa. Na ninajua hako na mipango mizuri ya county hii, sio tu kwa mambo ya saratani, lakini kwa shida zote za kiafya ambazo zinaweza kutukumba. Na tumeelezwa kuwa watoto, mnanisikia? Yes. Sitasema mengi sana kwa sababu waziri ataongea zaidi. Hiyo mambo ya SHA. Hebu watoto mseme SHA. Mnajua hiyo ni nini? Mkifika nyumbani, kila mtu ambia mzazi tujiandikishe kwa nini? Alafu iwapo tuko wagonjwa, tuende hospitali tutibiwe bila gharama ya kulipa, si ndio? Nimesema nini? Ukifika nyumbani uende useme nini? Sawa, asante sana. Ukifika nyumbani, hilo ni jambo, hata kabla hujasalamia baba ama mama umwambie sawa. Bima ya afya inaitwa na analipa tu pesa kidogo. Sawa. Ili watoto wote nyumbani, hata kama mko 10 ama 2 ama 5, tunaomba kwanza tukinge magonjwa. Lakini iwapo utakuwa mgonjwa, ukienda hospitali hautakatazwa matibabu kwa sababu utakuwa na Asanteni sana, Mungu awabariki.
Thank you very much. We are here from the Ministry of Health under the leadership of our Cabinet Secretary to increase the capacity for our county governments in provision of cancer care across the entire continuum of care. And we are happy that today we are here at Samburu County Referral Hospital for this very important activity where we have launched a cancer treatment center here. And it is not just about the launch, it is actually beginning with actual treatment. Today we have been able to treat 4 patients who have received treatment, and we've all witnessed, with prostate cancer and other different types of cancers on day 1. We are also happy to report that Samburu County Referral Hospital has a fully trained, qualified oncologist who is going to lead in the efforts of providing these services here in the county. It is an initiative by the Ministry of Health through the National Cancer Institute of Kenya to make sure cancer services are devolved to our different counties, and we've done this in many other counties. We are happy that Kenyans should not be traveling far away from their homes to seek treatments, and these are very expensive treatments. Sometimes patients struggle to even get transport to get to Nairobi, Eldoret, or Nakuru, where there are comprehensive cancer treatment centers. So this is quite a reprieve for the people of Samburu County and its environs, because they'll get treatment close home. And this is one way of reducing the burden of cancer. Access has been a challenge to most patients, and not only access to treatment when cancer has been diagnosed. There's also going to be access for diagnostics. There's also going to be access for prevention. There's access for screening, because this current administration is encouraging through Ministry of Health promotion and prevention of diseases in general, cancer being one of them, because that is the only way we can control these chronic diseases. Thank you very much. We are happy that Samburu County residents can get care close home. One other very important exercise that we are rolling out here in Samburu County is a Samburu County Cancer Registry. For a long time, because of the expansive county and the challenges of data collection, we have not had very clear data of ASAL counties in general. And the opportunity to begin this cancer treatment center gives us also an opportunity to get the correct data. So today, I may not give you the correct data, because what we have is very dismal, but we know it's because most people have not been coming for treatment. And now that we have a center here which is operational, which has all the human resource, we will get good quality data in due course. But as a country in general, the burden of cancer is rising day by day, but the Ministry of Health has put also very important strategies to make sure this is handled in due course. Thank you very much.
Rising cases. The last time we checked, we had 5 to 10 new cases every month. Does that worry you?
It is a concern, and that is why, through the support of the Ministry of Health and also the Parliament, whom they have promised to commit resources into cancer care in the country, we do believe that in due course we will have less people being diagnosed, because we'll be preventing more, and we will have better outcomes because we will be treating well those who are diagnosed with cancer, and therefore mortalities and morbidities will reduce in general.
Thank you.
Thank you very much.
Thank you so much.
Good morning. My name is Dr. Ezra Lekenit, Director of Medical Services, Samburu. So, cancer is an emerging issue in Samburu County, alongside other non-communicable diseases like hypertension and diabetes. I mean, the leading cancers are those of the GIT, especially the esophageal cancer. We also have cervical cancer among the ladies, breast cancer, prostate cancer, cancers of the head and neck, which are also significantly high in Samburu, so amongst others. In Samburu, we have an oncology clinic, and we also have a palliative care clinic. And we are attending to more than 100 patients in these clinics. Last year, we have had like 59 new cases, and these were cases we were able to diagnose and document. So this week we are expecting that we are doing screening for 4 cancers. That is breast cancer, cervical cancer, prostate cancer, and colorectal cancer. And we are expecting members of the public from Samburu County and its surroundings to come for the free services that we are offering. We are also expecting to treat those who will be found positive, who will be diagnosed of the cancer, will receive also free treatment. We are also registering all those who are coming with SHA. Yes, so we're expecting a good number of people to turn up and make use of the opportunity, and we are also expecting to launch our oncology clinic in Samburu County Referral Hospital with the blessings of the CS Health, Dr. Mulonko Barasa.
My name is Dr. Michelle Ngu. I work for the National Cancer Institute of Kenya as the head of the Cancer Prevention and Control Directorate. This week we are in Samburu County, where we are going to be running a screening campaign, screening for breast, cervical, prostate and colorectal cancer. We are here, of course, with the support of our strategic partners, that is AstraZeneca and Microbiology East Africa being the implementing partners. We also have our other partner, that is Microbiology East Africa, will be in running point on the HPV screening. We'll also be running active HPV vaccination campaigns for girls aged 10 to 14, targeting schools. And the key highlight of this event will be the official launch of the Samburu Oncology Clinic, where the chief guest will be Dr. Deborah Barasa. So what the National Cancer Institute is actually trying to do is making sure that as we run our screening programs, especially in the underserved counties, we also try to initiate what our mandate says, which is basically saying that we should establish cancer centers or treatment facilities so that people with cancer can be treated within their community, because this offers them social protection. And also when you look at the financial implication of, for example, the people in Samburu traveling to Nakuru for maybe chemotherapy services, the out-of-pocket expenditure is really high, and that makes them miss their regimens, their treatments. So our highlight for this activity will be, of course, the launch of this oncology clinic. Samburu County recently had one of their doctor undergo training in radio oncology at the University of Nairobi. He recently graduated and is back here. So we'll be working closely with him and also guiding the county government health services Samburu County to continuously ensure that we have these chemotherapy drugs for the patients to receive their care. They have a surgeon, they have a ENT surgeon, they have an obstetrician. So all the cancers that need maybe surgery first before we initiate chemotherapy, we can promise that we are going to put measures and structures in place to ensure that these patients in Samburu receive this care. So the National Cancer Institute also is very keen on awareness. So we've also engaged our community health promoters to also go into the community to educate the community about the early signs, especially of cervical cancer, breast cancer, colorectal cancer, and also prostate cancer, to make sure that they actually are willing to uptake these screening services when they are offered. Because one way we'll be able to beat this monster called cancer is when the community partakes in the screening activities and initiatives. Because if it's precancerous lesions, Samburu County is able to do the ablation for these clients.
My name is Pauline Denguris, County MP for Samburu, and also a member of the Health Committee. Today I'm so delighted to host our CS here and the team from the National Cancer Institute Center for coming to see what we are doing here in Samburu in terms of health provision to our people. And we have seen the good work that is going on, and we have also been able to share some of the challenges that we have seen preventing us from attaining actually the services that we want to deliver to our people. But we are happy the CS and the team was able to see the good work that is going on here. In terms of CHA, I know that Samburu County we are not doing very well, and she has cited out the challenges that we are facing. So many people live away from here. They are not able to access the registration, and we need to mop up. That is our role, and the county government, the partners who are here, and it's our responsibility. We are going to mop up and ensure that our people access services through CHA. We also want to strengthen the level 1 and 2 facilities facilities so that our people at the community level can be able to access services in the nearby dispensaries. We are also able to see the work that is done by our CHVs, and we are so impressed. So to thank the National Cancer Institute Center really for enabling Samburu County to start treatment today. This was our first day that we started offering the cancer treatment to our patients. We have been so much affected for our patients being transferred to Nakuru, sometimes going to Nairobi, and due to congestion they take a lot of time before they are initiated on treatment. But today we are happy because from today on henceforth our patients will be accessing treatment here, so they will not be traveling. They will get all that they will require in terms of cancer treatment here, and even identification of cases early. We have seen that most of our patients come to the facility when it's too late, and sometimes when the treatment cannot work. But now they will be able to identify the cases early and even screen those who are not sick, so that people can know their status before they get infected. So I'm so happy, and I want to thank the team for coming. Thank the Wasiri for getting time to come and visit us. It's not easy thinking of Samburu and getting you for the first time. We are really glad that you are here, and thank you for coming, and we hope that you will come again. I also want to thank the chairman and the CEO for National Cancer Institute for really partnering with Samburu County, and we still have a lot to do together, and I welcome you to continue partnering with Samburu County. I want also to acknowledge the work that is done by the Ministry of Health team led by our county government. They have really gone even out of their own way to ensure that most of the services that are not offered here are offered even with the limited resources they have. So I'm sure with the support from the national government, we are going to work together to ensure that our patients get comprehensive services they require. Thank you so much. Thank you.
Zaidi gavana niruhusu mpishe Daktari Elias Meli pia aweze kutoa remarks zake.
Your Excellency, Governor of Turkana County, First Lady Turkana County, viongozi wa wizara hapa ya afya county pamoja na viongozi wengine, our political leadership pamoja na wenzangu kutoka national government, washikadau wote, watu wa Turkana, echonga mamaje ayonga. Nimetoka wizara ya afya kule Nairobi, na tumefurahi gavana kufika kaunti yako, kaunti ambayo iko na watu wazuri, watu ambao wanapenda wageni. Ningependa kushukuru sana kwa nafasi hii. Tumefunguliwa milango yote, tumetembea kaunti hii, gavana wetu. Nimesikia ni gavana Simba Mkatani. Gavana, nimerealize these people love you so much. Na ningependa uniambukize kile uliwaambukiza pia. Sijui uliwafanyia nini, lakini nafikiri ni uongozi bora na maendeleo ambayo ishaonekana mapema katika uongozi wake, sio? Tumekuja hapa kwa sababu ya uhamasisho wa siku hii ya kusherekea mambo ya saratani katika dunia mzima, na nimetumwa na wakubwa wangu kutoka Wizara ya Afya, waziri wetu wa afya Daktari Debra Mlongo pamoja na principal secretary wetu Mr. Hari Kimutai. Mkiniona nikisimama hapa, mjue kuwa Nairobi iko na nyinyi, na mjue kuwa tunatambua kuwa Turkana ni county kama zile kaunti zingine zote 47 katika nchi yetu hii. Tumekuja hapa kwa sababu ya mambo ya afya, na mnajua kwamba serikali kuu, one of the flagship projects ni universal health coverage. Ninaongea kwa sababu kila kaunti yetu tumeulizwa tuhakikishe mpango huu wa serikali kuu iweze kuanza, kuendelea na iweze kutusaidia sisi. Tuko na nyanja mbili za government, national government kwa ushirikiano na county government, kazi pamoja. Na mnajua kwamba katika Wizara ya Afya kuna sheria 4 ambazo zilipitishwa na wabunge wetu hivi si mbali, na rais akatia sahihi kuwa sheria, kwamba mojawapo ni kuhakikisha kuwa sisi wote tukuwe na uwezo wa kulipiwa iwapo mmoja wetu anakuwa mgonjwa bila kubaguliwa. Mambo ya Social Health Insurance Fund, mambo ya Social Health Authority, na nimefurahi hivi majuzi tuliitwa kwa mkutano tukiwa wakurugenzi wakuu wote katika Wizara ya Afya. Tunafanya kazi pamoja kama jamii moja kuhakikisha this universal health coverage is successful, kwa sababu nimeona disparities nyingi. Mimi nimetembea nchi hii na nchi za nje, na gavana wetu, wakati tulikutana na wewe kwa ndege tukienda Nairobi, nilikueleza kuwa mimi ni CEO wa National Cancer Institute na tungependa tufike Turkana County ili pia tushughulikie mambo ya saratani. Na Mungu amependa tumefika hapa hii wiki, na hakuna uhamasisho imefanywa katika kaunti hii ama hata nchi hii zaidi ya yale ambayo tumeona hapa leo. Umoja ambao nyinyi mmeonyesha hapa ni wa kimataifa. Hebu tujipigie makofi jameni. Asante sana. Tumesema kuwa kila mtu aweze kupata matibabu bora, na nimejua kwamba katika hospitali yetu hapa uongozi hapa umefanya kazi nzuri. Your Excellency, nilikuwa na nafasi ya kufanya kazi wakati tulikuwa na district hospitals, na wakati tumetembea jana kule Lodwar County Referral Hospital, nikaona kuna ICU, kuna HDU, kuna maternity, na nikapata mahali ambapo pameandikwa oncology, ambapo inafaa kuwa sehemu ya kutibu wagonjwa wakijulikana kuwa na shida ya saratani. Tukitoka Nairobi katika uhamasisho huu, ile ya kufanya screening ni mojawapo ya initiatives katika National Cancer Institute of Kenya kuhakikisha kuwa janga hili ambalo linaua watu wengi duniani, nchi yetu na hata hapa Turkana County, ikuwe ni jambo ambalo tutazika katika kaburi la sahau. Nilisikia msanii mmoja hapa akiimba, alisema saratani ifanye nini? Ishindwe, si ndio? Na itashindwa tu kama tutaweka mikakati ya kuhakikisha tunakinga, na kama hatuwezi tukakinga, tugundue mapema, tuweze kupata matibabu, kama ni upasuaji, kama ni ile ya chemotherapy ama radiotherapy, ipatikane hapa Lodwar County Referral Hospital, ili msitume wagonjwa Eldoret ama Nairobi, kwa sababu hapa ni mbali. Jamana, nilitembea hapa kutoka Nairobi 15 hours and I came by road. Hiyo inamaanisha kama ni mgonjwa kwenda kule, inamaanisha watu wachache mno wataweza kupata matibabu kule. Tutahakikisha tunashirikiana na county. Niko na Daktari Epeb hapa, tulikuwa na mkutano kwa ofisi yake, na I am happy to announce kuwa between the national government and the county government through National Cancer Institute of Kenya, tutahakikisha hiyo sehemu ya kutibu wagonjwa itaweza kufanya kazi kutoka jana, leo na kwenda mbele. Your Excellency, I'm a cancer specialist. Mimi ni daktari pia mtaalamu wa kutibu magonjwa ya saratani. Jana tulikaa kwa clinic, tukawaona wagonjwa baada ya kutembea na mama wetu katika mashule kuhakikisha tumefanya vaccination na kuwafunza wasichana wetu. Tukakaa kule kwa clinic. Day 1 tumekuwa na wagonjwa zaidi ya 20. Mimi nina imani kuwa leo, kesho, wiki ijayo na wiki zijazo, wagonjwa watakuwa zaidi ya 100 ambao watakuwa wanatafuta matibabu hapa. Na ili muweze kupata hiyo nafasi ya kuhakikisha matibabu yako, lazima tuhakikishe kuwa madaktari wanaweza kukuwa trained ili waweze kupeana hizo services. Your Excellency, I have offered to train one of your medical officers akuwe daktari mtaalamu wa kutibu magonjwa wa kansa kutoka hapa Lodwar, kutoka hapa Turkana County. Mimi nitamlipia school fees. Nitaomba tu Dr. Epem amlipie mshahara wake ili aweze kujikimu kule Nairobi. Na tukiungana hivyo, tutahakikisha baada ya miaka 4 mtakuwa na daktari wenu hapa. Lakini wakati tunangoja miaka 4, timu yangu kutoka Nairobi, niko na madaktari wataalamu pamoja na washirika wetu kutoka Moi Teaching and Referral Hospital, tutatembea hapa kila mwezi kuja kusaidiana na madaktari wa Lodwar County Referral ili waweze kupata haya matibabu hadi siku ambayo mtakuwa na uwezo kama hapa County Referral Hospital. Now this one, we want to employ a strategy, Your Excellency, called Hub and Spoke. Hapa itakuwa the hub na sub-county hospital. Nilishangaa kuwa muko na hospitali zaidi ya 200 katika Turkana hii county. Wale wote kupitia hiyo Beyond Zero campaign na strategy ambayo Dr. Etem nafikiri ataweka kuhakikisha kuwa wale wagonjwa katika hospitali zote wakijulikana kuwa na kansa watumwe hapa ili waweze kupata matibabu. Ningependa pia Your Excellency na watu wa Turkana kuwaeleza kuwa ni mzuri serikali kuu ilituruhusu kama hospitali kuring-fence ile pesa ambazo mnazitengeneza hapa ili muweze kutumia kama county, kama sub-county, kama hospitali zetu hapa. Ile program ya kansa tutaanzisha hapa, ninaomba ile pesa ambazo zitakuja kutokana na kutibu wagonjwa, kwa sababu wote watakuwa members wa SHA, zibaki zijenge hiyo hospitali ya kansa. Na nina imani tukifanya hivyo, Your Excellency, watu wako wa Turkana, wa Kenya watukufu watapata matibabu kama sehemu zote katika nchi hii yetu ya Kenya. Nikimalizia, kwa sababu ninajua muda umeyoyoma, tutahakikisha kuwa washikadau wote ambao tumefanya kazi hii pamoja, tutaendelea kushughulika hadi wakati ugonjwa huu wa saratani, hadi wakati shida zote za afya katika kaunti hii na nchi hii zitaweza kushindwa. Leo Your Excellency, pia because we are launching hiyo cancer center hapa, nitakuomba wakati mgonjwa wa kwanza ambaye madaktari wenzangu wako kule kwa hospitali wanapewa hiyo dawa uweze kushuhudia, kwa sababu itakuwa na baraka zako na hiyo itasaidia. Kwa unyenyekevu, tukimaliza mkutano huu, niruhusu niombe sisi wote twende mpaka kule, tutawasupport na tutafanya yote yale ambayo yanawezekana. Mwenyezi Mungu na wabariki watu wa Turkana County. Tuende turudi ama twende kabisa? Tukirudi Nairobi mnatupatia salamu? Nichukulie waziri wangu pamoja na principal secretary wangu, ndio? Tumeshukuru sana, nyinyi ni watu wa ngwana, watu wazuri, watu wapenda wageni. Hatuna budi kurudi hili tuendelee na juhudi hizi kupigana magonjwa yote pamoja. Zaidi ni ile ya kansa ambayo kitengo chetu, taasisi chetu kinashughulikia. Mungu na wabariki sana leo na hata milele.
Nikasema siku ya saratani katika dunia ni lazima tuadhimishe siku hii kwa pamoja. Nikiwa mustaafu, nikataka kupongeza First Lady kwa sababu kwa mara ya kwanza alitoa mama moja akampeleka kule India katika matibabu. Pigia makofi. Nikiwa mstaafu nikasema vile vile DCC kwa niaba ya County Commissioner na timu yake ya security, mumefanya leo tuko hapa na amani tele. Nikiwa mstaafu nikazidi kupongeza Mheshimiwa Epe vile vile, kwa sababu wakati alikuwa CEO katika hospitali kuu ya Lodwar chini ya uongozi ya His Excellency Honorable Jeremiah Morkai, tukawa na oxygen plant ambayo inasaidia watu ya Southern Sudan, inasaidia watu ya Ethiopia, vile vile watu wa Uganda. Patie makofi tafadhali. Ikiwa mstaafu, nataka kupongeza timu yote kutoka Wizara ya Afya na washikadau. Ni kwa sababu katika Jamhuri ya Kenya, mimi 1998 nikasema huenda nikajiuzulu ama kustaafu. Watu wakasema katika Afrika Continental si rahisi rais kuacha power, lakini ikiwa mstaafu nikasema nitafanya kazi na serikali yetu liwe liwalo. Kwa hivyo nataka kukaribisha the former Prime Minister of the Republic of Kenya aweze kuongea kidogo. Mheshimiwa, karibu.
Lazima sema kwamba jambo kwanza, mimi nikiwa Mheshimiwa Raila Amolo Odinga, nataka kusema kwamba leo ni siku muhimu katika ulimwengu mzima. Wana wamekuja, mimi niliwaambia hii mambo ya saratani ukipimwa mapema, sasa wewe kuna vile utasaidika katika jamhuri ya Kenya na vile vile ulimwengu. Na mimi nikiwa Mheshimiwa Raila Amolo Odinga, mimi nataka kupongeza Wakenya wote kwa sababu tumekuja hapa ili tuadhimishe siku ya saratani kote ulimwenguni. Nataka kupongeza Chief Officers na vile vile wale washikadau wote kwa kushirikiana kwa sisi hapa kwa hapa. Na First Lady, sisi tunakuombea mambo mazuri. Vile vile mimi niliongea juzi na huyu current governor wakati amekimbia Saudi Africa kidogo, mambo ya hapa na pale, ili tujenge kaunti yetu. Wale nifunge kwa kukaribisha rais wa Jamhuri ya Kenya aweze kumaliza kwa dakika mbili. Mheshimiwa, karibu.
Na mimi nikiwa rais wa 5 wa Jamhuri ya Kenya, tumsifu Yesu Kristo. Mimi nataka mnipigie makofi wale mchezo bwana. Jambo la kwanza katika taifa letu, leo ni siku muhimu ya kuadhimisha siku ya saratani, si kweli? Sasa mimi nataka kuuliza kweli jameni, si nyinyi mmeona, pigia machifu na timu ya security makofi, maana barabara haijakuwa mbaya, patiwa makofi tafadhali. Nikiwa rais, mimi nitahakikisha mambo ya stima, vile vile mambo ya maji, mambo, si nyinyi mnaona gavana anapeana chakula bila wasiwasi, patie makofi mali yako. Na ndio tumesema katika taifa letu hatuwezi kamwe kusahau ile kazi inafanyika katika hospitali kuu ya Lodwar. Mimi nataka kuuliza kweli jameni, si nyinyi mnajua hiyo hospitali watu wanakula white meat ya samaki? Patia huyu mheshimiwa makofi tena. Na ndio tumesema vile vile hivi majuzi nikawaambia katika taifa letu tuko na mambo ya SHA, tukaeleza mjiandikishe ili muweze kufurahia huduma katika taifa letu. Mimi niliwaambia mimi ya kwamba wakati ile mswada ya kifedha nikawaambia hii kitu ni kuelewana, si kweli? Sasa mimi nataka kuuliza nikiwa rais mashinani hapa Turkana, ya kwamba ombi langu ni kwamba katika taifa letu tuweze kusaidiana, na vile vile nataka kupongeza gavana wa jimbo, maana hata kuna wakati wengine anapanda pikipiki kidogo anaingia hospitali kuangalia kama huduma iko sawa. Wewe unafikiri rais? Patie makofi bwana. Sasa mimi nataka kufunga kwa kusema hivi, katika taifa letu kuna hii majamaa rais wa mashinani kama huyu jamaa Kidela. Wengine wanasema hii jamaa zijana kata maji, sibatia kazi na kuone kama hawezi kuokoka. Mimi nataka kuomba napomaliza, maana nimekuwa na shida for 1 week na mambo ya landlord anadai shilingi 6,000, na mimi ni heri niongee ukweli. Nitaomba nipitie kwa first lady, nipitie kwa waziri, niende nimalizane na landlord ili ndoa yangu iwe na amani. Mnaniruhusu? Wananchi, simnipe makofi wakati kidogo. Na mimi naomba, nataka kuhakikishia kama leo mtanipea kazi yote ya security, mimi nitafanya kazi bila wasiwasi na nitaokoka. Kazi yangu ni PhD.
Ningependa kushukuru sana Wizara ya County pamoja na initiative ya First Lady kwa mpango huu, pamoja na Wizara ya Elimu katika sub-county hii na county hii kwa kupatia nafasi kuwatembelea. Nimesema ninatoka wapi? Nairobi. Wangapi wamefika Nairobi? Wangapi wangependa kufika Nairobi twende na wao jioni? Sasa mnajua katika serikali yetu kuu headquarters ni wapi? Nairobi, si ndio? Na nyinyi wote mtafika kule siku moja kwa mapenzi yake Mwenyezi Mungu, si ndio? Na ndio muweze kufika kule, mjikaze kwa masomo yenu hapa na mahali ambapo mtaenda high school, ili muweze kupata nafasi mkienda colleges, mtembee Kenya mzima, si ndio? Hata na nchi za nje, si ndio? Ninaona you are very beautiful girls. Because you are fearfully and wonderfully made, right? Yes. Na kwa sababu tunawajali, sisi tukishirikiana na idara ya afya hapa county, kutoka idara ya afya kule national government, kwa sababu tunafanya kazi pamoja, tumewatembelea Turkana County ili tuwahamasishe watu wa Turkana County wote kuhusu jinsi ya kukinga ama kuepukana na magonjwa ya saratani. Na initiative yetu mojawapo ni hii ambayo tuko hapa leo, ambayo inaongozwa na First Lady wa Turkana County. Tunashukuru sana, tumpigie makofi. Unajua, kama mama na mzazi, na sisi wote ambao tuko na watoto, tuko na dada na wengine tuko na grandchildren, tungependa sisi wote tukue na afya njema, tuepukane na tukinge magonjwa yote pamoja na saratani, ili tuweze kuishi jinsi Mungu amepanga, ndio tuendelee kujishughulikia katika maisha yetu, maisha za familia zetu na maisha za community zetu wakati tunakuwa, si ndio? Kwa hivyo leo tuko hapa kuwafunza tu yale ambayo huwa mnafunzwa na experts wa hapa county, lakini leo tunawaonyesha kuwa serikali kuu inawajali jinsi serikali ya hapa county inawajali na hata zaidi, na tunafanya kazi pamoja. Sawa sawa. Leo tunahamasisha kuhusu HPV vaccination. Na tunawauliza wangapi wanafanya sciences? Wangapi wameweza kufanya sciences? Hamujafanya science? Unajua curriculum ilibadilika. Inaitwa nini? You call it science and technology? Integrated science. Mumefunzwa kuhusu magonjwa? Si ndio? Kwa hivyo mumefunzwa science, si ndio? Na mojawapo tunasema tukingane na magonjwa, si ndio? Tunasema prevention is better than cure. Prevention is better than cure. Hebu nisikie kwa sauti, prevention is better than cure. Very good. Na tunasema hivyo leo kwa ile lens ya mambo ya cancer. Wangapi wamekuwa na mzazi nyumbani amekuwa
amejulikana kuwa na ugonjwa wa kansa? Mzazi ama jirani? Hebu nione kwa mkono. Umesikia kuwa mama ama baba ama ndugu anapata matibabu ya ugonjwa wa kansa either hapa kwa county ama hospitali zingine? Nimeona umeinua mkono. Ilikuwa ni kansa aina gani? Ya ubongo, ya kifua, ya tumbo, ya ngozi, ya breast? All right. So haya ni magonjwa. Hiyo ni moja hapo ya magonjwa ya kansa. Kansa inaweza kuwa ni ugonjwa inagusa mahali popote mwilini. Leo hii tunaongea zaidi kuhusu kansa ambayo inaitwa saratani ni ya shingo ama mdomo ya njia ya uzazi kwa kina dada na kina mama. Sawa sawa? Yes. Inaitwa cancer of the cervix. Na huo ugonjwa ni ugonjwa ambao unaongoza sasa hivi kwa kuua kina mama wakati wanajulikana na ugonjwa wa saratani. Cervical cancer is number 1 killer amongst our women. Mimi ni daktari ambaye ninahusika, ni mtaalamu wa kutibu huu ugonjwa wa kansa. Na kila mara nikikaa kwa klinikini, nikiona mama ambaye amejulikana na saratani ya cervix, majosi kidogo huwa inanianguka. Kwa sababu hii ni ugonjwa ambayo inaweza kingwa 100%. Hii ni ugonjwa ambayo haifai mtu yoyote hage kutokana nayo, kwa sababu inaweza kingwa. Na njia tu ya kukinga inaanza katika miaka yenu hii. Kutoka miaka 7, 8, 9, 10, 12 mpaka 15 kwa wingi. Kuna wale ambayo ni zaidi ya hiyo miaka ambayo pia wanaweza nufaika na haya matibabu ambayo tunaita chanjo. Ningependa kushukuru Red Cross na timu yote ambayo tunafanya kazi pamoja. Hizo boxes hapo ndani, maisha yako inategemea chanjo ambayo iko kwa hizo boxes hapo ndani. Na ni chanjo ambayo unachanjwa leo, kisha tunarudia baada ya miezi 6. Hata ingawa sasa kuna ujuzi mpya ambayo tuta roll out very soon, Your Excellency, ya single dose immunization against HPV, ili usije ukarudi tena baada ya miezi 6. Hiyo chanjo ukipata leo itakupatia kinga kwa mwili yako, ili wakati unakuwa ukianza kushiriki ngono, wakati wake ukifika katika ndoa, in case ukikutana na ile virus ambayo inaleta hii saratani, kinga yako itakuwa na nguvu na haitaweza kuleta saratani ya cervix. Mumenielewa? Yes. Maisha yenu inategemea nini? Hiyo chanjo. Kwa hivyo ninawauliza leo muweze kushiriki hiyo chanjo, ili isije ikakuwa njia moja ambayo itakupatia afya ambayo haitakuwa mzuri, ni ugonjwa wa saratani ya cervix. Sawa sawa? Na ni chanjo tu mara moja, na kinga yako inakuwa strong, na itakinga si kansa ya cervix peke yake, hata kuna kansa zingine ambazo tumejua kuwa pia hiyo HPV ina cause, itasaidia pia kupigana na hayo. Lakini zaidi ni hiyo saratani ya cervix. Sawa sawa? Hebu nisikie mkisema HPV vaccination. HPV vaccination. Hebu nisikie mkisema against HPV virus. Against HPV virus. Which causes cervical cancer. Which causes cervical cancer. Hebu turudie tena, HPV vaccination. HPV vaccination. Against HPV virus. Against HPV
virus.
Which causes cervical cancer?
Which causes cervical cancer?
Kama mutasahau mambo yote ambayo tutasema hapa leo, musisahau hizo sentensi ngapi? 3. Sawa sawa?
Yes.
Na zaidi ya hayo muende mufunze wengine nyumbani, si ndio? Yes. Mutasema wataalamu kutoka serikali kuu kule Nairobi wakishirikiana na wataalamu kutoka hapa county na First Lady wa Turkana County pamoja na washirika wengine wengi wamewatembelea leo kwa sababu wanawajali. Sawa sawa?
Yes.
Ningependa kutamatisha hapo nikiwatakia kila laheri, nikiwatakia afya njema. Ya mwisho, kama watoto ambao wanakuwa, wasichana wetu ambao tunawapenda sana, tunawauliza pia musiweze kushiriki ngono mapema. Don't start engaging in sex early. Ninawaomba, sawa sawa?
Yes.
Si kuna wakati utafika. Ha? Na wakati huo utafika kwa sababu hiyo ni njia ya maisha, si ndio? Baada ya ndoa utakuwa na nafasi ya kujenga familia yako vile wazazi wenu wanajenga na nyinyi watoto mnakuwa, si ndio? Ikifika wakati huo utakuwa na nafasi ya participate in sex kwa sababu ni haki yako katika huo mpangilio. Kwa sababu njia moja ya kuinfect hiyo virus ni through sexual intercourse. Sawa sawa?
Yes.
Ikiwa ni mapema, vijana wakijaribu kukuuliza, uambie unaogopa mambo mangapi? HIV and also early pregnancy, si ndio?
Yes.
Kuna kitu inaitwa triple threat. Mmewahi sikia hiyo kitu? Yes. HIV, early pregnancy and now cervical cancer. Haya mambo matatu yataharibu maisha yenu kama itafanyika sasa hivi. Sawa sawa? So ninawahamasisha, ninawauliza muweze kuepukana nayo ili muishi, muendelee na masomo yenu, mkuwe madaktari, mkuwe mawakili, mkuwe walimu, mkuwe accountants na all other disciplines ambazo mungependa kuwa, si ndio? Asanteni sana. Mungu Nirudi tena? Nirudi tena? Hii ya mwisho? Haya, nitakuja tena ili tuweze kujifunza zaidi. Sawa sawa? Asanteni sana.
She's saying she's Esther Wharton. Anasema mambo yenye inafanyika hapa about vaccination, it's so much okay.
Chamakana apa tu dangu apa te mas mamne pipil arai jika joko juko ngana lilim.
Anasema kupimwa si chungu kabisa. So anawakaribisha wamama wote wasiogope waje wapate kupimwa ambaye ni cervical cancer.
Ketere edekelo abua lalara lo turkwan. Acha magana cha gupon dangu epimasi sodi eso yarte edekelo kina kinere dawa.
Anasema hii ugonjwa wa kansa imekuwa mingi sana huku Turkana County. Ndio maana anawakaribisha wote, wanawake wote waje wapimwe cervical cancer.
Yana bangi delo chamakna ema seda wala polio. So di tamate da ngolo ketere edeke lo buntina balode.
Anasema kuna vaccination ambayo inaendelea, that is for female, wasichana miaka 14 wanapata vaccination ya cancer. So anawakaribisha nyinyi nyote wamama pamoja na watoto wenu, wamama wakuje wapimwe cervical cancer na watoto wakuje wapate chanjo ya HPV. Anasema that is all. So all women, you are all welcome for this activity.
Aya, daktari wetu anapeana hiyo chanjo ya pili. Atapata kadi sasa yake. Okay, tuko karibu kwa akipata chanjo tushangilie. So, First Lady anapeana kadi ya kumaanisha ya kwamba amepata chanjo, alafu pia atapata kit ya Sharon Wapili. Sharon Chiwai. Makofi. Thank you. Aya, daktari wetu anapeana hiyo chanjo ya pili. Atapata kadi sasa yake. Okay, tuko karibu kwa akipata chanjo tushangilie. So, First Lady anapeana kadi ya kumaanisha ya kwamba amepata chanjo, alafu pia atapata kit ya Sharon Wapili. Sharon Chiwai. Makofi. Thank you.
Mimi hufanya shairi na mimi hutunga shairi zangu mimi mwenyewe najifanyia, alafu bado mimi huomba vile naweza nikapatana na President William Samoei Ruto tuweze kuongea na yeye about mambo ya kansa. Bwana asifiwe. Shairi langu linaenda hivi: si mimi peke yangu niliyetolewa matiti, kunao wengi wa mama wametolewa matiti, pia hata na wababa wametolewa matiti, tumebaki hoe hahe, rais utukumbuke. Saratani imetutesa na kutusumbua, imetunyang'anya watoto hata na wazazi, Wazazi twalia watoto, watoto walia wazazi. Ewe Mwenyezi Mungu, tuondolee janga hili. Sio sisi peke yetu ambao tumeathiriwa. Kunao wengi wenzetu pia wameathirika. Wengine wametolewa vizazi wazai tena, wengine wameng'olewa macho hawaoni kamwe. Saratani imetutesa na kutusumbua, imetunyang'anya watoto hata na wazazi. Wazazi walia watoto, watoto twalia wazazi. Ewe Mwenyezi Mungu, tuondolee janga hili. Twapitia mengi na machungu, lakini twavumilia. Hatuna wa kumwambia, twabaki vuta majonzi. Saratani imetutesa na kutusumbua, imetunyang'anya watoto pia na wazazi. Wazazi walia watoto, watoto walia wazazi. Ewe Mwenyezi Mungu, tuondolee janga hili. Natamatisha shairi langu lecho nililotunga, nikitumai ya kuwa Rais atatusikia, atuondolee gharama, kansa itibiwe bure, nchi yetu isonge mbele. Bwana asifiwe.
I'll wake up, it's a sunny day. Grab your shovels, come away. It's our birthday, let's make a start. Planting trees with all our heart. Our birthday, our birthday. Let's plant a tree and pave the way for a green earth, come what may. Celebrate the Arbor Day. Seedlings ready in the ground, water them all around. Watch them grow year by year, a greener world, let's cheer. Arbor Day, Arbor Day. Let's plant a tree and pave the way.
In this video, we'll cover the basics of stomach cancer. What is it? Who gets it? The symptoms, diagnosis, and treatment. Whether you're looking for answers for yourself or someone you love, we're here to give you the best information available. Stomach cancer, also called gastric cancer, can happen in any part of the stomach. However, in the US, most stomach cancers occur in the gastroesophageal junction, which is where the esophagus, the tube that carries chewed up food, meets the stomach. There are several different types of stomach cancers, but most are curable if detected at an early stage. What once was the leading cause of cancer death is now well down on the list thanks to the advancement in technology and scientific research. In fact, new cases of stomach cancers have dropped by about 1.5% every year for the last 10 years. Stomach cancer more commonly affects older people. The average age of those diagnosed with stomach cancer is 68. Around 60% of cases occur in patients older than 65, and there is a slightly higher lifetime risk of stomach cancers in men. However, it can affect anyone. Stomach cancers tends to develop slowly over time, usually over many years. What happens is small changes occur in the DNA of the stomach cells, telling them to overmultiply, and then they accumulate, forming abnormal growth called tumors. There are several known risk factors that could increase your risk of developing stomach cancer. For instance, smoking doubles your risk of stomach cancer. Family history of stomach cancer, infection with H. pylori, long-term stomach inflammation, gastroesophageal reflux disease, or stomach polyps. Eating a diet high in salty and smoked foods or low in fruits and vegetables can be also a risk. And there is some correlation between higher weight and risk as well. Stomach cancer can present itself in several different ways, such as difficulty swallowing, feeling bloated after eating, feeling full after only eating small amount of food, heartburn, indigestion, nausea, stomach pain, unintentional weight loss, and vomiting. If you have any signs and symptoms that worry you, make an appointment with your doctor. Your doctor may investigate the more common causes of these symptoms first, or refer you to a specialist like a gastroenterologist, or an oncologist like me. To determine if you have stomach cancer, your doctor may start with an upper endoscopy, where a tiny camera is passed through the throat into the stomach. If your doctor finds something suspicious, they remove some tissue for a biopsy, where the cells get sent to a lab for further analysis. Your doctor may also run some imaging tests, like CT scan or a special X-ray called the barium swallow. Identifying the extent of the cancer helps your doctor determine the best treatment. To determine the stage, they will run more tests like blood tests, endoscopic ultrasound, CT scan, or a PET scan. In some cases, your doctor might recommend a laparoscopic surgery, where the doctor inserts a special camera directly into the abdomen. Creating a treatment plan for stomach cancer is a collaborative effort between doctors from different specialties. Our goal is to make the best treatment plan for your overall health and personal well-being. There are 5 main treatment options for stomach cancer. Surgery to remove all of the cancerous tissue and probably some of the healthy tissue around it. Chemotherapy, which uses drugs that journey throughout the body, destroying any cancer cells in its path. Radiation therapy, which uses high-powered beams of energy to target cancer cells. Targeted drug therapy, focusing on blocking specific weaknesses present within cancer cells. And immunotherapy, a drug treatment that helps your immune system recognize which cells are dangerous and attack them. Finding out you have cancer can be really overwhelming and difficult. It can help to find spaces where other people understand what you're going through. Try connecting with cancer survivors online or in your community. Learning about your condition can help you make confident decisions about your care.
Hamjambo, Your Excellencies, thank you for inviting us here today. My name is Benda Kitaka, and I would like, because I'm standing here on behalf of the National Cancer Institute that's leading the response against cancer, I would like to ask of you to give us your indulgence for just a few minutes, and I will request the following persons with great humility to just come forward with me. Kindly, Dr. Elias Meli, the CEO, National Cancer Institute. Dr. Miriam Mutebi, a breast cancer surgeon at the Aga Khan University Hospital, and the president-elect of the AOTIC, the African Organization for Research and Training in Cancer, and the past president of Kenya Society of Hematology Oncology. I would also like to request the PS representative, Dr. Martin Sirengo, to come forward kindly. The reason I'm asking for this is because when we were told that we were going to come and represent, I had prepared 100 jokes about running, because I cannot run to save a life. However, I know that today we have 3 technical experts that can give us under a minute things that we need to know about cancer as we prioritize cancer care in Kenya. Kindly, Dr. Elias Mele.
Allow me to greet you in the name of Jesus. Good evening. Our host Governor Jonathan B., Excellency Governors present, Council of Governors, all dignitaries, all protocols observed. We are humbled to be here this evening to speak to you about what has really bothered most of us. My name is Elias Meli. I am from Uasin Gishu County, and I'm glad to be home. Thank you very much, Uasin Gishu County, for granting us this opportunity to share with you in 1 minute. We are the National Cancer Institute of Kenya, mandated with cancer prevention and control. We are here to give you hope. We know that we are going through a very difficult time in our health, and we are here to encourage you that this disease which has terrorized us physically, economically, socially, and spiritually, we have been mandated to bring it down. We did it with HIV, which harassed us 20 years ago, and it's in control now. I'm not going to take much time. We have our strategies with you that we have shared. We have our branding materials. We will be coming to your counties to support you as county governments. We would want to celebrate devolution in this country that has enabled our health in our counties to improve. We will be coming to each of the 47 counties as National Cancer Institute of Kenya to develop county cancer action plans so that you can seek treatment from your vicinity. You will not be traveling to India or to Nairobi, far away from home. We are developing regional cancer centers, and I know our able governors here are very happy with that. And we are going to have cancer control centers very close to you. Allow me, with humility, to invite Dr. Miriam Mutebi. She is one of our celebrated cancer specialists in this country in 1 minute. And she's been elected to represent the entire Africa in research training. We are a blessed nation. You know how our president leads by example, and we have many uncelebrated, quiet ones in this field. Welcome, Dr. Miriam Mutebi.
Thank you so much, Dr. Meli, and Your Excellencies, ladies and gentlemen, Chamugay. I want to talk very briefly about one of the issues that I think is close to all our hearts, and that is health. We know that we've all been dancing here and really having fun and celebrating, but then really thinking about that quite enough for the longest time. And many of our patients had very little to dance and smile about. And why is that? That's the reason is because we are seeing an increase in the number of patients who are getting diagnosed with cancer. And what we've been seeing is that not only are these patients diagnosed late, they frequently do not complete their care. And if we do a deeper dive into the reasons behind this, we find financial factors, the fact that patients have to pay out of pocket, which has been mitigated partly by the NHIS, the fact that patients in Kenya will see on average 4 to 6 healthcare providers before definitive diagnosis of their cancer is made, and the fact that things we don't talk about, the fact that we are many different cultures, social-cultural barriers such as stigma, collectivism, that all translate into poorer patient outcomes. However, this is not a message of doom and gloom, it's really a message of hope. How do we work together? I always say I'm in the hope business, and I think really part of the strides around that have been changing narratives around cancer, and how can each of us here change the narratives for our cancer patients? The first thing is we are seeing an increase in the number of cancer facilities, centers of excellence. We're now having a vibrant National Cancer Institute that's really leading the charge in how to support care, but we've seen an increase in the grassroots advocacy around how do we work together collectively to become our brothers keepers in order to improve care. So in summary, I would say let's work together thinking about the patient journey, whether it's the cost of care, which is a real thing. Let's work together. We're not just looking at siloed approach. We want to see how do we get everyone to the table? How do we manufacture our own drugs? How do we manufacture our own expendables? We are currently paying 3 to 4 times the same cost for a cancer drug than anywhere in other countries. That is unacceptable. We are currently having to manufacture and import our cancer implements. How do we work together? How do we get the manufacturers? How do we get the financiers to work together with us all to change narratives for our patients? Thank you.
Thank you, Dr. I would like to invite Dr. Martin Sirengo, who is representing the PS Health. Thank you.
Thank you. Your Excellencies and all protocols observed. My name is Dr. Martin Sirengo from the Ministry of Health. I'm representing the PS Medical Services, Mr. Hari Kimtai. I was asked to speak about what we are doing to assist in cancer control in this country. And when I was coming here, and I saw the people seated here, I kept wondering, are people ready to listen to this when probably, and my co-speakers, the only people between you and the dinner? But I would like to thank the organizers of this event, first for putting up entertainment, because one of the things that we must do at an individual level and family is exercise towards prevention. Now, why is cancer so important? And I would like to ask a question here. How many of you have been affected or know somebody who has cancer in the past 2 years? By show of hands. The number is huge. And even if you've not been affected, I am sure you have been a member of the WhatsApp group to contribute money to support someone who has cancer. And therefore, cancer is such an important agenda in the national government as well as counties. We're working together. And for us to be able to provide the services, we have put in place policies that guide our cancer control response. We just finished implementing the 2017-2023 cancer control strategy that had key pillars in terms of cancer response. The first one being aware, primary prevention. Being aware and doing things that will prevent us from getting cancer because of the many risk factors that we know. Infections, sedentary lifestyles that we have, nutrition, sources of water, and all that. Number two, early detection. Distinguished guests, the unfortunate thing about cancer is that by the time someone goes to hospital, chances are that they are already advanced. In this country, we have over 40,000 cases every year. More than half of that die eventually because 7 out of 10 cases that we see come when it's already too late. And so early detection means that we need to get the initiative within ourselves to go for screening, to do things that will keep us healthy. And we have partnered with counties to make sure that the low-level health facilities through the primary care networks are going to be equipped. Some are, of course, have been equipped to provide those services for screening for cancer services. Just as basic as taking your blood pressure, your weight, and all that. Number three, treatment. Dr. Lenny talked about us setting up centers of excellency for cancer treatment. Of course, we have the national referral hospitals, which are the hub for cancer response, but we are also setting up the spokes, which are the regional centers. In the first phase, we have managed to set up Garissa. Is now functional, Mombasa is functional, Nakuru is functional. The next center that's going to be constructed is Kisii, and others will follow. And of course that will supplement what the level 6 hospital like MTRH here, the KU referral, Kenyatta doing. And lastly is the issue of palliative treatment and supporting people with cancer. Cancer comes with a lot of stress and affects families to the level that some of them have been able to sell everything. And therefore the level of mental illness around cancer is a real issue and we need to address that. And for us to do all these things, we must have the right equipment, the right infrastructure, we must have healthcare workers who are able to provide these services, and for all the things that we do, we must monitor, we must measure. And lastly, we must invest in research. And together, I think we'll be able to fight this cancer problem. Thank you.
Thank you so much. I think the one component that was left out, and I want to appreciate all the speakers, is the community. And I stand here representing the community. The people you raised your hands and said they have been affected by cancer, the people in the households that you're taking care of, and the people that we want to help to prevent. Two messages. The first one, we have a vaccine in this country that's targeted at girls who can prevent cervical cancer, and yet it's the leading cause of cancer death in Kenya. And the uptake of that vaccine is really dismal. So we have to do something as communities to understand there is one cancer we can beat.
And my ask of each one of you is when you live here, when you leave the land of champions, be a champion in your community to get girls to prevent cancer. The second message, and this goes to all of us who fear talking about cancer. It's a weighty matter. It's something that should not be taken lightly. But we have people in our communities who have lived experience. They have gone through treatment in Kenya, they have been taken care of in Kenya, and they are living examples that you can live and thrive beyond cancer. Let us equip them so that they become the last mile to reach the community with the knowledge that there is life beyond cancer. Your Excellencies, allow me to recognize the board of NCI. Can you just stand up so that people can clap for you? That's part of the representation that's leading National Cancer Institute in leading the response against cancer, and the staff members who made this possible. Kindly stand up. Now, I would love to spend more time and tell you about the 100 jokes that I had you may see, but time is not on our side.
Dr. Mary, are there many cases of children, or do you see more and more cases of children with cancer?
Well, Jeff, the statistics are alarming. On a daily basis, many of cancer incidences, cases are recorded on a daily basis. Let me confirm to you that the National Cancer Institute of Kenya is the custodian of all cancer data in this country. We have a national cancer registry, and this includes data from childhood cancer diagnostic and treatment centers. They are on the rise. But interestingly, between adults and children would present in a manner that you can hardly suspect, because they would present with the normal illnesses. You've had Honorable Munene here mention that it was tonsillitis. Trust me, that child had been sick for the last couple of years, because carcinogenesis process does not begin, in a month and you become unwell. Yeah. Most likely, the bone marrow is an organ in itself. And acute lymphoblastic leukemias, which his daughter was diagnosed with, interestingly, when diagnosed in a setup where there is the requisite, infrastructure, where we have the right human resource, the right commodities, even without bone marrow transplant in the West, acute lymphoblastic leukemias can be treated with a cure rate of more than 80%. And we've demonstrated, when I began my practice, we had almost 100% mortality rates in acute lymphoblastic leukemias. But right now, at Moi Teaching and Referral Hospital, where I've worked for the longest time before I joined National Cancer Institute of Kenya, we have cure rates of more than 50% over the last 5 to 10 years because of a program which is dedicated to treating children. And in this country, for us to address childhood cancers, the approach is totally different from adults, because these are guys that you cannot screen. These are people that you need to have high index of suspicion for you to make a diagnosis. So having our healthcare workers to learn how to suspect so that you don't end up treating a pneumonia or maybe pain in a prolonged time, and ultimately it becomes cancer when it has spread. I want to, reference, in this world, we have 75% of cancers are diagnosed in the West. 25% are diagnosed in low medium income countries, where Kenya is one of them. But unfortunately, 75% of mortalities are in LMICs. What have they got it right that we don't have it here? But allow me to appreciate that so much has changed over the last 10 years in our country. Our government has really invested both in adults and childhood cancer treatments. And we're not looking at only treatment. The most important thing is to make the right diagnosis.
It is Nahume Chawafula, but instead I have Dr. Elias Meli from the National Cancer Institute of Kenya. We also have Dr. Primus Ocheng, who is the Program Director at the University of Nairobi Oncology Training. I have one Dr. Naftali Busakara, who is from KESHO. KESHO means Kenya Society of Hematology and Oncology, and of course, Governor Muthomi Njoki, the Governor of Tharaka Nithi County, and also the Chairperson of the Health Committee at the Council of Governors. And let's begin with you, Dr. Meli, because we've had so much, especially talking about the diagnosis diagnosis process. So the various experts are talking about the index of suspicion. Maybe you can help us understand, in the country, what is the status of diagnostic capacity, and what are these facilities that can be in a position to do this, and what is the sort of referral mechanism that we have?
Well, thank you, Sam and Christine, for having us tonight. We are glad that for the first time in our country, we are having such a national conversation on an issue which is really key, and it's causing a huge, burden in our community, socially, economically, spiritually, and giving it this immense attention will definitely go a long way to improve, diagnosis of cancer if we can not prevent. You've asked me a direct question on cancer diagnosis in this country. But before I talk about that, allow me to just mention that the National Cancer Institute of Kenya has this responsibility to coordinate all cancer activities in the country. And it was established because of the huge burden of cancer. We know globally the burden of cancer is quite high, and regionally and nationally, and we can see this even in our communities. And every family is affected. We are all affected. And our country has put in very clear strategies now to address this challenge, looking at it through the entire continuum of care, from prevention to early detection, diagnosis, and treatment. If we look at diagnosis, the question you've asked me, Sam, over the last 10 years, after devolution, there is a lot that has improved in terms of diagnosis in generally for conditions across the country, without talking about cancer, because you present when it is not cancer. You present to the hospital when we are having symptoms that we are not specifically sure that this is cancer. But in the process of the doctors, talking to you, taking that history, examination, all that leads towards diagnosis of cancer before we consider now imaging, which would lead us to know there's a growth, because cancer, predominantly, cancer would begin from mutation, an error in DNA, which is pretty much our genetic makeup.
Right.
And then it grows, it multiplies uncontrollably, excessively, and it has capacity to spread from one point to another. So when it multiplies excessively, then this is when we now see a growth. And this is when symptoms would present, probably pain, probably obstruction of a lumen, and someone will present. That is when the doctor now will ask for imaging. And when you ask for a scan, you are likely to now pick there is a growth. So in terms of diagnosis, we have two modalities. You diagnose using what we call pathology, or you diagnose using what we call radiology and imaging. Pathology is where once we have scanned and we found out predominantly most solid tumors. We also have blood cancers that you will not see a growth, but most solid tumors, if you are going to scan and you find there's a growth in the abdomen, in the brain, on the breast, or in your cervix, then that is using X-rays, ultrasounds, CT scans, MRIs, and now PET scans. In our country, the capacity has increased immensely over the last 10 years. And almost every county, through the MESS program, almost every county now has increased capacity in diagnosis. We almost have a CT scan in every county. Lately, through our strategies to improve cancer care in our country, we've been doing every county cancer action plan. And we have noticed most counties have CT scans capacity, because that's the basis of diagnosis on radiology and imaging. We have a challenge, though, in pathology.
Okay.
Where we have very few doctors in that area, and we have very limited equipment and infrastructure. But certainly, there is a lot of improvement.
Okay, and we'll get to that question of the index of suspicion, because it may speak to capacity, especially of the human resource, but also to inform you that this broadcast is in partnership with the National Cancer Institute of Kenya. NCI is an agency under the Ministry of Health that coordinates all cancer activities, from prevention, early detection, diagnosis, and treatment of cancer across all continuum of care through quality service delivery, training, and research towards reduction of the burden of cancer in Kenya. Christine?
Waziri wa Afya Bi Susan Nakhumicha Chande wamejiunga nasi katika mazungumzo haya. Karibu sana waziri. Hapa mjadala unaendelea ni kuhusu masuala ya kansa, matibabu, gharama ya matibabu, aina mbalimbali za kansa. Tuna wataalamu katika studio zetu hapa, tuna wale ambao wameugua kansa, wale ambao wamepona. Kwa hiyo tungependa kufahamu pia kutoka kwako, manake utafiti unaonyesha kwamba kati ya 70% na 80% ya wale ambao wanagunduliwa wana saratani wanagunduliwa wakiwa wamechelewa sana, wakiwa wamefika stage 4, stage 3 na stage 4, ambazo wataalamu wanasema kwamba kidogo inakuwa ni changamoto. Kwa hiyo tungependa kufahamu kutoka kwako kama ambaye anasimamia hii idara ya afya nchini kwamba je, kama mipango Wizara ya Afya na serikali kwa jumla, ni mipango ipi ambayo mnaweka kuhakikisha kwamba utafiti ambao unafanywa, tuna mashine, wataalamu wa kutosha kuweza kutambua mapema ikiwa mtu ana kansa, manake hii kungoja sana inaleta changamoto.
Asante sana Christine, nashukuru idara hii ya Citizen kwa kunialika nije niongee na Wakenya na pia kwa kuangazia mambo ya saratani. Na nashukuru kwa sababu naona umeleta mtaalamu wangu, my senior advisor Dr. Meli, ambaye ndiye Chief Executive Officer wa National Cancer Institute, na hii ndio mbinu moja yao ya kuweza kuwajulisha Wakenya na pia watu wengine kwa ujumla juu ya hali ya ugonjwa wa saratani. Na vile umesema, na niliingia daktari pia akiongea, ugonjwa wa saratani ili tukaweze kuangamiza kwenye nchi ni kuhakikisha ya kwamba tunaweza ugundua mapema, kufanya screening ya mapema ili ukaweza kugundulika. Wao umesema vilivyo ya kwamba wagonjwa wengi wanajulikana wakiwa wako kwenye stage 4. Hiyo inamaanisha matibabu inakuwa ni ya bei ya juu, na pia ugonjwa unapatikana ukiwa umeshaenea mahali pengi mwilini. Unajua saratani ni ugonjwa ambao una multiply haraka. So kama serikali kuu na wizara, umeona tumezindua juzi mpangilio na tumesema ya kwamba sasa sisi kama wizara tunataka sasa kuhakikisha ya kwamba tuna focus mambo ya primary health care. Ya kwamba tuwe sasa, muda mwingi ambao umepita tumekuwa tukishughulikia mambo ya matibabu ya kihali ya juu, na ili hali ugonjwa mwingi tunaweza kuzuia tuki concentrate na primary health care. So kama wizara sasa tumefocus, na ndio kwa maana tuko na wale tunaita community health promoters. Unajua tuko na 1,100 nchi mzima, tumewapatia vifaa ya kuweza kuenda kwenye households, kwenye community, manyumbani. Kila community health promoter mmoja anashughulikia watu 100. Mbona tumefanya hivyo? Sisi tunataka kuhakikisha ya kwamba tunazuia ugonjwa kabla ufanyike, na pia tunaelimisha watu mambo ya hali ya afya. So katika hiyo hali au community health promoters wanafaa kuwa kukuelimisha, lakini pia wakisha kuangalia, kuongea na wewe, uwe uko na muda wa kuongea nao kuhusu hali yako wewe kwa ujumla. Wakipata ya kwamba uko na ugonjwa, basi wanakurefer kwenye mahali ambapo unaweza pata usaidizi ama unaweza pata matibabu. So katika hii hali ya kung'ang'ana na hii ugonjwa wa saratani, nimesema the most important thing is screening. So wale community health promoters, najua maswali ni kwamba je, wataweza kufanya screening, but I want to encourage Kenyans ya kwamba community health promoter, huyu mhudumu wa afya wa nyanjani, akija kwenye nyumba yao, talk about your health in total. Ongea mambo yako ya kiafya kwa ujumla. Unajisikia vipi? Je, unaona uko sawa? Ni nini umeona ni kama inaweza kuwa kuna kasoro? Unajua Wakenya ni watu ambao ni wavumilivu sana. Mtu anaweza ona hata ako na uvimbe, lakini anaona sina maumivu mengi, haendi kwa matibabu. Anangojea mpaka ile siku yenye ugonjwa itakuwa imemziba kabisa, ako na maumivu makali, ndipo anaenda. Sasa hawa community health promoters, Wakenya wakaweze kuwa na mazungumzo nao. Akija kwenye nyumba yako, mueleze hali yako iko vipi. Wewe kama ni mume, mke wako wako vipi, watoto wako vipi? Je, kuna kitu unatazama katika mmoja wa your family members ambayo inaonekana kama si ya kawaida? Je, labda mtoto amekuwa akikohoa muda mrefu ambao sio wa kawaida, ama labda we ni mama ukiosha mtoto unaona kuna uvimbe ambao unaona si wa kawaida, labda hakuna maumivu lakini kuna jambo ambalo si la kawaida. So tunataka kuhakikisha ya kwamba hawa tunawatumia kuanzia chini kabisa kwenye household, afya nyumbani, waweze kuangalia ni vipi basi tutaweza kuhakikisha ya kwamba Wakenya wengi tumezuia ugonjwa, tumewaelimisha juu ya ugonjwa, na wale ambao tunapata wako na shida yoyote wamekuwa referred mahali pale wanaweza pata matibabu.
And Waziri, we'll get to more interventions, but let's hear from the counties because, Governor, you lead a county and devolution has been on for more than 10 years now. Health is basically quite devolved apart from the policy direction that may come from the ministry. But what would you say is the true picture on the ground? You can start with your county specifically, but also the bigger picture across the counties when it comes to the diagnostic capacity. Yes, we hear of screening, that you want that the health workers are as suspicious as possible, but what is the capacity that you'd speak of?
Thank you very much, and allow me actually not to start with the counties, allow me to start with myself. Because I would be like to speak to the Kenyans that when we talk about cancer, it's a national conversation that affects anybody in this country. It is not for the poor, it's not for the rich, it's not for those who are ignorant. I say I start with myself because I always give this story. My father was a nurse, and even as he was treating other people, he developed a pimple on the neck, and I remember him saying when I was a small boy that I do not want to go to hospital in Nairobi because I don't want to be found with cancer. You know, that kind of attitude. And eventually that pimple developed to something else, and to cut the long story short, my father eventually got cancer that affected his ears and I think TNC. We spent a lot of money here on, and at that time there was we did not have advancement in chemotherapy. Mostly we used radiotherapy. And eventually we lost him. And I remember saying to myself, never again. Because had we taken our dad to hospital in good time, probably early detection would have saved him. I said never again. But 28 years later, when my mother was diagnosed with a stomach problem that we took to several specialists in stomach. And eventually she was diagnosed with stage 4 of pancreatic cancer, which the doctor tells me is usually very hidden. It is the one that actually kills Steve Jobs of Apple, and with all the money that he had. It means that the attitude, even out there, because I've had one patient there saying that there's usually stigma among our patients. When somebody is told you have cancer in Kenya today, first thing that comes to their mind that there's a possibility that I'll go. Why is this the case? As I talk about the counties, if you look at the global picture of cancer, the whole world, 70% that is killing people is happening in middle-income countries and low-income countries. Do we have bodies that are different from the first world countries? Of course not. There must be something that they're doing that is different from what we're doing that is making them not see cancer as a threat, because almost 95% of their patients recover. And that is what we need to address. And it basically boils down to the issue of the cost of almost every stage of cancer, be it diagnosis, be it screening, all the way to the treatment in this country. Right. We must address the issue of the cost, access to this treatment, and even their diagnosis. In the counties at the moment, we have only 10 cancer centers in the whole of Kenya, in actually 10 counties at the moment. We were in the process, I think, of increasing to with another 4. I'm not very sure that it's been done. But that tells you that not every county can be able to do diagnosis, screening, to the level that they go to treatment without having to move to a neighboring county.
So the cancer centers are for basically treatment?
They are basically for treatment.
But what is the capacity for diagnostics?
The capacity for diagnosis, from the level 3, it is possible to do simple diagnosis like pap smear. They are also able to do VIA. We are able to do mammogram in level 4. We are able to do also, we are able to use CT scan probably for those who have radiologists. However, there are counties that do not have the personnel to be able to
Can you be specific? Tell me the story of your county.
Yes.
Are you able to screen and tell people this is what you're suffering from? Or it has to be somewhere else?
Well, I have to be factual. Up to some extent, we do clearing and forwarding in terms of we do not have the capacity because our county does not have MRI. If we need something that needs to have a scan with MRI, we have to send to Nairobi. CT scan is possible. But again, it is not every radiographer and radiologist who is able to detect cancer. Okay. We need an oncologist radiologist.
So Nairobi is your nearest?
Nairobi is our nearest. Okay. And just to make it very clear, in the counties, when you look at the number of oncologists in the whole country, in the issue of HRH, the number of nurses who have done radiography, you might find that in a county, you might find only one or maybe two. You may find there's no such doctor in such a county. And therefore, and it's not because counties don't want to employ. You advertise and you don't get anything.
Okay.
Last time I checked with yeah.
We'll get to more details about that.
Yes.
Christine?
Dr. Naftali Busahala, wewe unatoka katika shirika la Kesho ambalo linafanya utafiti juu ya saratani na magonjwa ya damu. Katika hiyo sekta ama nyanja hiyo ya utafiti, je, ni mipango ipi ambayo mnafanya kuhakikisha kwamba saratani inaweza kugunduliwa mapema? Manake kilicho wazi hapa ni kwamba kugundua saratani imekuwa ni changamoto.
Asante sana Christine na Sam. Tumefurahi kuwa hapa na asanti kwa wote ambao wamehusika kuhakikisha kwamba huu mpango unaendelea. Katika Kenya Society of Hematology and Oncology, yani Kesho, dhamira yetu ni mbili. Dhamira ya kwanza ni elimu, education for members, kuhakikisha kwamba tuko na qualified manpower, not just at the level ya specialization, lakini pia subspecialization. Dhamira ya pili kwetu ni research. Na kwa hii dhamira tuko na ile inaitwa research committee ambayo inahakikisha ya kwamba tunafanya ile mentorship. Hiyo ndio kitu ya kwanza na hiyo ndio kitu muhimu sana. Kuhakikisha ya kwamba wale ambao wote wanataka kufanya utafiti katika hii nyanja ya kansa wanasaidiwa kuandika zile proposals zao. Na wanasaidiwa pia kuonyeshwa pale funding inapatikana. Na pia wanasaidiwa kufanya ile tunaita publication. Kuhakikisha ya kwamba zile articles wameweza kuziweka pahali ambapo watu wanaweza kusoma. Kitu ya pili ambacho tunaangazia sana ni awareness. Utafiti kuhusu awareness. Tunataka ya kwamba watu wakuwe their own champions about cancer, so that waelewe mili yao, wajue ya kwamba shida ikitokea hapa ndio tutafanya. So tuna utafiti kuangalia specialists, na kuna utafiti pia kuangalia the general population. Yeah, so hivyo ndio tunafanya.
All right.
Katika Kesho.
All right, Dr. Primas, talk to me about, because you're in the training area and obviously the health workers are from different cadres and different levels will be working at different facilities. Like he says, there are challenges when they want to hire, they cannot find a lot of talent to get their employees from. But what are the challenges and what would you say is the training output, especially for the diagnostics level?
So thanks so much, Sam and Christine, and this is a very great opportunity for us to tell Kenyans what the government is currently involved to actually improve cancer care. So when you get sick, you need a diagnosis, and you need a diagnosis, you need a doctor. We have had many doctors in this country, and remember before our diseases were malaria, TB, and HIV, and government had put so much money, and many doctors were trained, and we had enough doctors. Then suddenly cancer came. And remember, before we thought cancer was a disease of the Europe. So in the last 10 years, the government has now tried to shift its paradigm in disease management and move from malaria, TB, HIV now to the new disease cancer, and of course also the other non-communicable disease. So this caught many African countries and not Kenya alone, that suddenly we didn't have doctors to be able to treat cancer, to treat patients, to diagnose them. We didn't even have centers. For a long time, it was just Kenyatta alone. And so the University of Nairobi, where I come from, there has been a lot of work to actually help in diagnosing cancer. So cancer diagnosis is very complex. It's not like any other disease. When you have, say, malaria, the doctor takes blood from you, check it under a microscope, look at it and get it. In cancer, the diagnosis starts with the doctor who knows about cancer. As everybody has said, cancer comes like any other disease. Like Waziri's, it was a pimple. So you must have a doctor who knows the pimple there can actually be a cancer. So you must train that doctor, and the doctor must know that it is something suspicious that he needs to do more about. Then the next important thing is that you must prove that you have a cancer cell. And that means the little lump or the little growth or whatever you get must be checked under a microscope and confirmed. So these are called the pathologists. And the pathologists do so many checks that the pathologists who actually just check the cells and say this cell is abnormal. But you need a pathologist who can tell you that this cell is not only abnormal, but it is cancerous. Now, it is always very difficult to tell what is normal from abnormal, because cancer cells sometimes are very close to the normal cells, or they may be just starting. And so you need it to be very, very different. So you need to stay, and that is one of the areas where we actually are struggling, because we don't have enough pathologists.
Right.
And that's why, as Waziri was saying, specimens are coming from all over the country, still have to be checked in Nairobi, because we have probably about 90 pathologists in the country to do the diagnosis. Well, we also need many other pathologists, because we need only currently the government is training pathologists, but some have to help do the postmortem, some have to help do the laboratory work, some have to help in actually diagnosing other diseases, and then you have to train them. We currently are training pathologists in this country in about 3-4 universities. But for a long time, many doctors have been attracted also to other areas of specialization.
Right.
You know, all of us, we want to go into an area where we earn more. So people would like to become neurosurgeons, because we all believe neurosurgeons are very tough people. They can do a better work than a pathologist. So more doctors have been attracted to certain specialties and not like pathology. So that also explains why.
Okay.
Again, oncology, where now once the diagnosis is made, you need oncology to treat and also help. We also lack oncology, because doctors actually at first were not so attracted to oncology, because the oncologists probably were people taking care of cancer. And one time we thought cancer was a disease that if you get it, you die. And no doctor wants to spend his time taking care of those who are going to be lost. They wanted to take care of those who are going to, like hypertension that we keep seeing. Yes.
And later on, we'll speak to Waziri to tell us about the policy interventions, at least to improve the numbers of people that can be in a position to do that. But Dr. Meli, talk to us about, because of all these challenges of diagnostics and the capacity that we are talking about, what is the bigger picture, and what do you think would be a solution to ensure that even as we encourage, because Waziri says that there is the community health promoters, what is the bigger picture so that people don't have to travel from Tharaka Nithi to Nairobi for certain processes of this diagnosis?
Well, thank you, Sam. I think if there is anything we should celebrate in this country, is devolution. Because healthcare being a devolved function, then devolving in our constitution healthcare, if we really have to address this issue to make sure that we reduce, the burden of patients being referred to urban centers, predominantly Nairobi and Eldoret, where there is more capacity in cancer care, as the other upcoming, urban Nakuru, Mombasa as well. So the best thing that we can do in this country is to make sure we build capacity in our counties. And if you look at resources that goes into building capacity in our counties, it's still quite limited. I'd mentioned earlier on that as of today, we have assisted our counties, 20 of them, to develop each county-specific cancer action plan. And one of the thematic areas that we're looking at is cancer diagnosis. it is quite unfortunate that there are some counties that would not, have any investment in that area. And coming in with our technical assistance as a role of the National Cancer Institute of Kenya, we are showing them that yes, you can, and we can work together with the assistance of the national government and working with the county government. We can actually commit resources and we can have a plan. We have a national sector cancer strategy, and it has highlighted how we would want from the national, and I know later on we may have to go through that policy document because it's quite important. But if we're going to improve capacity in our counties and find ways of making sure we invest in infrastructure in our counties to make sure we have the requisite buildings, we have the requisite equipment. We are also looking at human resource, very important, human resource in health. It is probably one of the most costly, intervention that every county needs. And not only training, we also need to find strategies on how we are going to retain them. Because again, most doctors who are being trained by rural counties, a lot of them ultimately, move to urbanized counties, Nairobi, Kiambu and Kajiado around Nairobi, or Uasin Gishu County, Nandi, Elgeyo Marakwet, where they are within, an urbanized area. So we need to find ways of motivating them to remain in the rural counties. And we are discussing with them. And I'm happy because having this discussion at this national level, I am very sure after this, there are going to be clear strategies on how to support them. And we are not only looking at HRH as well, we are looking at commodities that they need for diagnosis.
Okay.
When we've been discussing with counties, they have a lot of challenges on reagents. These are quite expensive. If you look at screening for cervical cancer, for instance, you are doing HPV, test DNA or RNA. If we were to speak on the terminologies that we need to use in diagnosis, most counties cannot afford these reagents. And they're important in early detection of HPV, that is one. So we really have to invest in human resource, infrastructure, equipment, and commodities.
Who can make those detections? Who can detect that? Which facilities?
Currently.
You said many counties can't.
Many counties can't, especially histopathology is quite a challenge. If you look at the counties that have capacity, I can mention a few. Of course, Nairobi County, Uasin Gishu County, Mombasa County. We have Kakamega County. We have Kisumu County. We have Kisii County.
Okay.
And
Nakuru.
And Nakuru County.
Okay.
We also have a lot of support from
kiwango cha level 6.
Exactly. Most diagnosis of cancer is made at level 6 hospital, or level 5 at least, because we have level 6 hospitals. We only have KUTTRH, Moi Teaching, Kenyatta. Those ones are fine. Those ones even have training programs. And the level 5 that we have mainly, it's Mombasa, Nakuru, Jaramogi Oginga Odinga, and Kisii and Kakamega.
Asante sana. Sasa hivi tunakwenda katika hospitali ya Chuo Kikuu cha Kenyatta. Hii ni hospitali ya rufaa na mafunzo. Mwenzetu Lilian Muli yuko pale na pia na maelezo zaidi.